You guys see it okay? Eventually, I'll get the splitter so that it'll show up on that TV too, but I haven't quite got there yet.
You're alive.
Thank you. All right. Okay, good morning. Does anybody have any questions about what we went over on Monday? Any questions? Everybody good? All right. So between last class and today, you guys had chapter 1 to read in the yellow book and the test on page 181 to take in the spiral book. Did everybody do that? Okay. If you did not, it's okay. I'm not that kind of a teacher. Okay. But I'm going to go down my list and call your name. When I call your name, let me know how many you missed or what your score is. And you get the score on the answer sheet, on the answer key down here. It has a grading scale. It tells you if you missed 1, you got a 95. If you missed 2, you got a 90. So either tell me how many you missed, or if you did the conversion, tell me your score. If you did not get to it, just say pass, or I'll get it to you later, or something like that. Okay. All right, Kaylee. Okay, Annalise. Nicole.
I didn't miss any.
Okay, good. Candace. David.
100.
Thank you. Ronisha. Thank you. Michaela. Thank you. Jacob. What is it? 80. Got it. Shayante. Okay. Let's see here. Julie.
I did all but grade it.
I'm sorry.
I didn't grade it.
You did. That's fine. I'll get it from you next class. Elizabeth.
I did do it, but I didn't do some other questions.
Okay, that's fine. I'll get it from next class. Russell. Thank you. Finley. Gabriella. Yeah. Gabriella, on the front of your book, the yellow book, there's a number. What number did you get? Y5. Got it. Isabella. And Medina.
90.
Thank you. Did I call everybody? Everybody good? Okay. All right. So at the beginning of each class, from now through class 6, that's going to be important to you in just a minute. From now through class 6, we are going to have a review of everything that we covered up until that point. So it's a quick review because in this class, we're going to build on the principles that we learned. So if you didn't master these principles, today's lesson isn't going to make a whole lot of sense for you because we're going to build on it. Now, I know that there's days in between classes, right? So between Monday and Wednesday, you got Tuesday. A lot can happen in Tuesdays. But between Wednesday and Monday, you've got 4 whole days, and whatever I put into your brain is likely to leak out. So we go through a pretty comprehensive review at the beginning of each class just to make sure that what you've learned stuck so that we can build on that. Now, that's up through class 6. Class 6 There we go. Okay.
All right.
So let's try that. Double check me. Sorry, guys. Virtual people.
All right. We have sound back.
All right. Good job. Okay. So how do we know what to do with each patient? Care plan. Okay. So we're going to follow that care plan. Who writes the care plan? The nurse. What do you do if you can't follow the care plan? Tell the nurse. So this is going to come up at some point in the class. Somebody is going to ask, well, what if the patient says no? What if you go in to do a skill and the patient doesn't want that skill done? What if they say no? What do you think you need to do? Okay, so we're going to ask why nicely, because the nurse is going to ask you why, and you're going to notify the nurse. We don't, good morning. We don't change anything. We don't make decisions. We don't force the patient to do anything. Now, that word force, what does that word mean? Force. If I forced you to go outside, what does that mean? Okay, so it's exerting your will over somebody else's, usually in a physical manner. Make sense? That's a good definition of the word force. Well, is that something that CNA should be doing? Remember what I said on Monday? Help isn't help if it doesn't help. You guys remember that? That needs to be in the back of your mind at all times because we are helpers. That's what CNAs are. We help the patient. We help the nurse. We are helpers. And help isn't help if it doesn't help. So if you are forcing a patient to do something, you took a wrong turn somewhere. Not our job. That's not helping. So on the written test, you're going to have probably 2 or 3 questions on the written test where one of the answers is going to say force or coerce or, some sort of very strong negative verb will be there. That is never, ever the right answer. You can automatically get rid of that answer. It will never be the right answer. I don't care what the question is telling you. It's not the right answer. Does that make sense? So remember that force or make somebody do something or restrain somebody, never the right thing. So as a CNA, we're going to read the care plan and we're going to follow that care plan. And we're not just going to read and follow the care plan. It's the care plan, the whole care plan. You can't pick and choose what parts you want to follow. You've got to do the whole thing or none of it. Good? Makes sense? And then you'll notify the nurse of anything that you see. So it's the care plan, the whole care plan, and nothing but the care plan, which means we can't change anything. And everything we know, the nurse needs to know. Good? Make sense? All right. Any questions on skill rules? Do you guys know how to figure out what you're supposed to do? Read the care plan. This care plan should exist in every setting that a CNA works. So if you're working in a hospital, you'll have a care plan. If you're working in a nursing home, you'll have a care plan. If you're working in home care, you'll have a care plan. But I want to talk about assisted living for a second, because assisted living is not a medical setting. This is something that's very confusing and very misunderstood. So let me kind of go through the healthcare settings with you very briefly. In a perfect world, on a perfect day, you will be completely and fully able to care for yourselves until you die. You'll never need help in a perfect world on a perfect day. Do you think that's realistic? No, you're going to need help. Even if you're young, you may need help because you had a surgery or you picked up a porcupine and now you've got quills in your hands, whatever situations life throws at you, you're still going to need some help at some point with something. Now, normally we're going to rely on those closest to us, our parents, our siblings, our significant other, our friends. We're going to kind of tap our local network, right? As we get older, though, that local network gets smaller and smaller and smaller. Most people would prefer to stay in their own home. Even when they're not able to do things all on their own, they still want to be at home. So they start hiring help. They hire somebody to mow the lawn. They hire somebody to come in and clean. They hire somebody maybe to take them to doctor's appointments or go pick up their groceries or DoorDash type thing. They hire, you guys all probably use some sort of help, right? Because we are a convenience-based society. So you have people going and running and doing things for you so you can stay on Netflix. Those types of services will also be used by those that are homebound. But when you start bringing in a lot of services, it gets very expensive. So if you've got somebody mowing your lawn, cleaning your house, running your errands, making you meals, and then you got to hire somebody to help you with bathing and dressing and grooming, all of that together, plus paying for your house and your electric and your insurance and your car and all, it gets very, very expensive very, very quickly. So there are some people who look at the finances and they think, you know, it would be cheaper on me if I just went into a place that had all of these services built into the monthly cost. So I'll pay rent and get all of this stuff. Make sense? That's what assisted living is. Not medical. Not medical. This is an apartment situation, just like if somebody went and rented an apartment, but it comes with all these services built in. So laundry services, cleaning services, cooking services, transportation services, and in most cases, you can buy a package that gives you so many hours of personal care services. That's all assisted living is. Now, there's some assisted living facilities that have an additional license that lets them provide a little higher level of care. That's called a limited nursing license. And that just means that we can now employ nurses that can take care of wounds and help patients with medications and stuff like that. Still not medical. Okay. Does that kind of make sense to you guys? So in assisted living, because it's not medical, you're not going to have a care plan. Not medical. Don't need a care plan because it's not medical. So how do we know what to do in an assisted living facility? Well, even though there may not be a care plan in that setting, there's usually a list of services that are being provided to that client, that customer, not patient, client or customer. Does that make sense? You guys following that? So you would go by that list of services. Basically, they're paying for the service. Here it is. Anybody ever go get like a manicure or pedicure? You know how you get a menu and you get to choose what you're going to get off of the menu? You know, do you want the basic package? Do you want the hot stone? Do you want the extra massage? Right? You get to pick. And they're going to provide the services that you paid for. It's same thing in an assisted living facility. They pick the services and they pay for them. You provide them. Good? Makes sense? Now, nursing home, same situation, right? We're still helping them with bathing, dressing, grooming, all of that. They're still paying a monthly fee and they get room and board and laundry and meals and all of that kind of stuff. Same thing, but it's a much, much more expensive monthly payment because now we're going to include medical in there. We're going to be doing tube feedings and trach care and oxygen and blood sugar monitoring and all of those nursing things. That's why we call it a nursing home, because there's nursing services that are required. If you don't need a nursing service, you don't go to a nursing home. You go to assisted living. Cheaper.
I work in an assisted living that has dementia and stuff. So
Yep.
we have med techs and things, and we actually do follow a care plan.
Okay.
So is that like just rare?
So yeah, remember I said some assisted livings have that additional license. So yours
okay.
has that additional license. And if they're taking care of dementia patients, they would have to have nursing assessments and things like that. Okay. Does that kind of help you understand the little bit different levels of care? If there's a care plan, we're going to follow it. If there's not a care plan, there's going to be something that gives you an indication of the services that are being paid for. Now, if you go out to work on your own and you decide to be your own boss, be a CNA and hire privately, you're going to have to work with the client to figure out what services they're going to pay you for. And this can be a very difficult conversation. But what happens if there's a conflict later? If they say, well, I hired you to do this and you're not doing it. There's nobody to help mediate that conflict. And that can get really, really tricky. So understand that if you decide to go private, there are some potential conflicts down the road. So I would really make sure that you're laying everything out in writing very clearly from the very beginning to make sure that both sides are covered. Make sense? All right. So this tells us what. Now we're going to get into how to do it. So everything starts with a care plan. That tells us what to do. Now we're going to learn how to do whatever the care plan is telling us to do. So every skill is going to start with the opening, every skill. And every opening starts with a knock. It is a graded checkpoint. Remember that. You have to knock or announce loudly that you're going to enter the room. Imagine for a second, we've got a patient who finally managed to drift off to sleep, because we talked on Monday about how, rest is really hard to get in an institution setting. They finally managed to drift off into sleep, and now they're in a really, really deep sleep because they're totally exhausted. And subconsciously, they kind of hear something in the back of their mind, and their eyes pop open, and they're staring at a stranger standing right over them with a sharp object in their hand. How do you think that person's going to react? Negatively. I'm the hit first, ask questions later type. And most of your patients are too. Remember, they are in a strange place, surrounded by strangers, in a dependent position and not dressed for company. A lot of people are going to assume the worst here. Now, we don't think along those lines because we're fully dressed, standing upright, and we're there to do a job. So we are not on the same wavelength, this person and I. And it's my job to understand that, not their job to accommodate me. Do you guys understand that mindset? Okay. So knocking becomes super important. That keeps this location safe and secure for our patient so they feel comfortable going to sleep. Because if they have a chance of waking up and having a complete stranger standing over them, they're not going to rest well. They're always going to be on alert. Now that adrenaline, that always on alert feeling, that being on edge can actually impact healing because it impacts blood flow. Causes vasoconstriction, blood doesn't get to the areas it needs to get to for healing. That has a medical effect. But it can also affect medication metabolism. So the medications we give our patients may not be as effective because they're in that constant state of fight or flight. So this knock sounds super simple, easy to overlook, doesn't really make any difference to you, but to the patient, that knock is critical. It keeps the environment safe. Make sense? Good. Okay. Once you knock, you don't have to wait for a come in. We don't have to wait for that. We're just going to enter the patient area for the test. In a clinical setting, I'm waiting for that come in. I'm waiting for an acknowledgement because maybe your patient is on the bedpan, needs to finish up. or they're doing something very private, or they're having a private conversation, I'm going to wait. If I don't hear anything after a couple seconds, I'll knock again. If I don't hear anything, I'm going to open that door a little bit and say, hey, it's Patty, the CNA. Everything okay in here? Can I come in? Because maybe they just didn't hear me. TV was up too loud or something like that. So I always give a knock, a second knock, and then a verbal. And that helps keep my patient's space sovereign, but it also attends to their needs as well. I'm going to tell you, this is way more important than you think it is. So don't ever go barging into your patient's room. When I was in nursing school, of course, I thought I knew everything, right? I was getting ready to graduate. I was like a month away from graduation. We were doing our final clinical hours. So I was like this close to being a nurse, right? I could see it. And I'm all excited. I think I know everything there is to know. And I was assigned to a young woman. She was in her 20s. She had 2 or 3 children. She had just had one, so she had a newborn. She had 2 or 3 children altogether. And she was diagnosed with end-stage ovarian cancer. She was dying. There was no treatment to offer. And she had had a complication that made her go into the hospital while they were treating the complication, and she became my patient. Remember, I'm this close to being a nurse, super close to the finish line. And as a brand new nurse, I'm full of myself. And I didn't knock. I just walked in the patient's room. Hey, it's Patty, your nurse. She was in the final intimate time with her husband before she died. And I walked in on that. That is something I can never take back. That is something that I robbed not just her, but her husband of. That was 35 years ago. And I still think about that situation. I had no right to take that from them. Knocking is important. You never know what's on the other side of that door. And there's some things that you cannot take back. Okay? Once you knock and you enter the room, you're going to greet the resident. We want to be nice. Anybody ever see a CNA out there that's not nice? We've got plenty of those. We don't need any more. We need a healthcare team that is compassionate and empathetic. And that starts here, not out there, because out there is going to try to grind you down. If you don't have this in you from the very beginning, you're never going to gain it out there. So greet the resident. Good morning. Hello. I have a theory in life. I think everybody is born with a bucket of nice. I think you're born with a bucket full of nice. Kids are always nice. Kids are fantastic, right? Kids are rarely grumpy unless things aren't going their way. They have nice. But unfortunately, over life, you start handing your nice out. You hold the door open for somebody. You tell somebody that they look wonderful today. You spread your nice around. But the problem is that bucket is finite. And unless somebody else is filling your bucket, you're going to run out of nice. And it usually happens about 70 years old. Most people over 70, they're not very nice. And it's because they've handed out all of their nice and nobody has stopped to refill their bucket. How can they give you something that they don't have? So when I see somebody that is acting grumpy or grouchy or irritable or mean, I'm going to turn up the nice because clearly they need a little bit in their bucket. How can they give me something that they don't have? So when you see somebody that's grumpy, don't respond in kind. Well, she started it. Give them a little bit more nice. And eventually, when you do that long enough, they'll finally start having some to give back to you. Make sense? That's my theory in life. So we're going to greet the resident. We're also going to address them by name. Now, I usually do these two together. Good morning, Miss Jones. Good afternoon, Mr. Jones. You can do these together. That's fine, but you want to greet them and address them by name. Do not use honey, sweetie, lovey, whatever pet name you want to pick. Don't use those. First of all, it's a checkpoint. It's a checkpoint. Don't use it. But we want to be seen as professionals. You want professional pay, don't you? If you're not portraying yourself as a professional, nobody's going to pay you as a professional. They're going to get you as cheap as they can. So if you want better pay, you've got to start acting professional. That means the way you dress, the way you carry yourself, the way you interact with team members, and the way you interact with the patients. There's a lot of unprofessional CNAs out there, and they're dragging you down. They are absolutely dragging you down. Don't be one. I'm all for better CNA pay. And I will advocate that until my last breath. But there's something on the other side of that equation too. That's your responsibility. Good? Makes sense? Okay. So when you're talking to the patient, you want to do everything professional. Now, I personally don't like first names. I don't like it. I don't think that we should be on first name basis with our patients. I understand that's the norm out there. It's our society where that's just the way we are now. I don't like it because there needs to be a separation, a professional gulf there for me to be able to do what I'm going to do with this patient, right? I'm getting into their most intimate places. I'm doing things that they wouldn't be comfortable having their own family do. This is very, very intimate, the relationship we're about to have. And if I don't have some sort of a separation there, it can very quickly turn into something different and make one or both of us very uncomfortable because we're too close. Does that make sense? So I don't like calling this person Matilda. Now, I understand that's what we do now. But whenever possible, I stick to last names. I like Mrs. Jones. Mrs. Jones works well for me. But if she says, oh, no, I'd really rather you call me Matilda, then I'm going to call her Miss Matilda because I'm still gaining that little bit of separation. Good. Now, that isn't graded. You can do with that information what you will. But I am letting you know that the closer you get on a personal level to the patient, the more uncomfortable some of these skills may become for you and them. Having that little bit of separation can be very helpful. Good. Okay. Especially if you need to get them to do something that they don't want to do. Being too close, that can make things difficult. Once we have that out of the way, they need to know who and what we are. Now, a lot of you are going to say, this is just the first time I walk in the room, right? I don't have to do this every single time I walk into the room. No, you do. You do. And the reason for this is that when you don't introduce yourself at every patient encounter, you are putting the burden on the patient. Have you ever met somebody and go, oh my gosh, I know your face. I can't remember your name. I don't know where I met you. I'm not sure what you do. I recognize you, but I don't know who you really are. Have you guys ever had that experience? It's very uncomfortable because now you're trying to figure it out, right? So you're putting that burden on the patient. Remember that there's about 17 people that come in and out of that room every single day. And all of them are dressed in pajamas. Yeah, we color code them, but do you think the patients know the color codes? The staff don't even know the color codes, right? So don't put that on the patient. Not to mention the fact that they're sleep deprived, self-absorbed. Remember, we talked about this on Monday. Sleep deprived, self-absorbed, and distracted and medicated. They need to know who you are every time. Now, at some point in your working with the patient, they may say, yeah, I know your name. I got it. It's good. You don't have to keep telling me. Then you can drop that part. But how do you know tomorrow they're going to be just as lucid as they are today? What if they get a urinary tract infection? Because in the elderly, a urinary tract infection, the first symptom is confusion, not pain, not burning, not irritation, not urgency, not frequency, not all the things that we experience as young people. It's confusion. Now, you don't know that they're confused until you walk in the room. So for me, I introduce myself for every patient encounter because it gives me an opportunity to see where my patient's at. Good? Questions? Are you starting to see that this is a little more involved than just the words on the screen? There's always a story behind the words. That's what I need you to get. So, hi, Miss Jones. My name is Pat. Yeah, yeah. Knock, knock, knock. We're going to enter the room and greet the patient. Hi, good morning, good afternoon, hello. We're going to identify our patient by name, Miss Jones or Mr. Jones. And then we're going to tell them who and what we are. So I'm Patty, your CNA today. Good? Good. Now, once we get all the pleasantries out of the way, we're going to tell them why we're there. And you can read that right off the care plan if you want to. You can put it in your own words. Keep it professional. I would want to say I'm here to do peri-care, or I'm here to clean your private area, or we're going to get you cleaned up down below. I can say anything like that. I do not want to say I'm here to clean your hoo-ha. And we're not going to use slang. We're not going to make this cutesy. We're going to remain professional. Once I let them know what I'm there to do, then I need permission. So is that okay? Is that okay? For the test, they're always going to say yes. Thankfully, we have a pleasant and cooperative patient for the test. They do not throw you any curveballs. How many of you guys have a live human at home that you'll be practicing on? I recommend that you find one. Okay, live human at home. When you are working at home on these skills, when you're practicing, you need to go home this weekend and tell your live human that your instructor said that they have to be pleasant and cooperative and them. No curveballs. Because your family and friends think it's cute and funny to throw you all kinds of curveballs when you're practicing. That does not prepare you for the test at all. At all. It is not helping you. All that's doing is fulfilling their need to be cute. And it's not about them. It's about you right now. And that's exactly how you have to say it. When you say it like that, they'll calm down and they'll do what you need them to do, because the test does not throw you curveballs. You will be pleasant and cooperative during the test. Good? All right. Once we have permission, we can close that curtain. Is that curtain clean? What do you want to do? Wash your hands. That's right. After you've washed your hands, then you can go get your supplies. At the bottom of each skills page is the list of supplies that you're going to need for that skill. Again, you have to learn these. We'll get into that a little later. And then once you've gathered your supplies, we have to remember this is our foundation principle that overruns everything else. Do not touch the patient until your hands are clean. Period. Period. If you touch that patient before you've washed your hands, it could fail the test. Okay, good. All right, we also learned the closing. So the closing is what we do at the end of every skill. And these two together, your opening and your closing, makes up about half of all of your checkpoints. Abby says, I passed first try. Thank you so much for your class and your videos. They helped me so much. Good luck, guys. Congratulations. Good job, Abby. Very good. Hey, Jake, can you bring the mouse over to the MacBook, please? Other way. Yeah, there we go. There we go. Thank you. I can't read the whole comment there. Okay. So when we're ending the skill, There's a whole lot of C's here. We're going to make sure the patient's in a clean and safe environment. So that means look around. Is there a barrier on the table? We're going to talk about barriers today. Is there a barrier on the table? Are there dirty linens that need to be put away? Are the sheets adjusted well? Is there trash on the floor? Just look around. Always leave your patient looking better than you found them. So my LPN instructor from 35 years ago tunes in every once in a while. I'm still in contact with her. And she's the one that taught me that. Always leave your patient looking better than you found them. And I've always kept that principle in the back of my head. So make sure they're in a clean environment. Bed height always has to be in the lowest position. And we're going to talk about that in a future lesson, why this is important. But bed height needs to be in the lowest position. We're going to ask about comfort, and they need to hear that word. Are you comfortable? You have to say the word. But it's not just physical comfort that we're worried about here. It's also emotional comfort. So we'll address their preferences. Ask them, do you want a magazine? Would you like the head of the bed up? You know, whatever their preferences are. Good. Remember, it's always about the patient. We're going to ensure they're covered. So either a sheet or clothing, whatever, but no knobby knees. Okay, I don't want to see their knees. And you want to make sure that you open the privacy curtain and give them their call light, because they have to have a way of reaching you after you've left the room. So all of those things have to be addressed. All of them. I don't care what order you do it in. Give them their call light first. Then ask about comfort. Open the curtain before you give them the call. I don't care how it's done. It just all needs to be done. So create your own little blurb that you say at the end of every skill so that you're always saying the same thing every time. Makes it easier. So for me, it's thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Okay, your environment's clean. Bed is in the low position. Here's your call light. Open the curtain. That's my closing. Now, once I've done all those things, I have cootied up. I am cootied all over. So what do I want to do? Wash my hands. I got to go clean those cooties off of my hands. So I'm going to go clean my hands. If I have to document, I need clean hands to do that because the pen goes home with me. Anything that goes home with you, you should have clean hands to touch. Now, that's a hard principle for you guys because you're physically attached to your phones. I mean, right now, where's your phone? In your hand. So most of you guys will have your phones in your pockets. And if it rings or buzzes or does anything, what are you going to do? Reach in, pull it out, and you're going to take a look at it to see if it's something that you need to address right now or if it can wait till your break. You will touch that phone 1,000,000 times a day. Are you touching it with clean hands? How many guys ever use your phone as an actual phone? Like you call people? Yeah. When you call somebody, where does that phone come? Right up here, right up against your face. Is that phone clean? And you're putting it next to all of your holes. So anything that goes home with you at the end of the day, you should only be touching with clean hands. Now, right now, you're working with phones that have Walmart germs. They're just basic community germs. They're not really hurting you. You've developed an immunity to most of them. It's not a really big deal. But in a hospital or a nursing home setting, do you know what kind of germs we've got there? They're not Walmart germs. These are germs that are bad enough to make somebody sick enough to not be in their home. You want those germs in yours? So if you're going to touch anything that goes home with you at the end of the day, your phone, your keys, your wallet, your lunchbox, your pen, what kind of hands should you have? Clean. Good? Make sense? Okay. Once you've cleaned your hands and documented, we have a principle here that we have to remember: end skill with clean hands. So once you've washed your hands and documented, you have to go back and wash them again. So that's the very last action we do. We end the skill with clean hands, and then we don't return back to that patient. Because if you go wash your hands, write down your reading and wash your hands again, and then come over and say, all right, Miss Jones, I'm going to go ahead and go. Let me get you your call light. Here it is. Here's your call light. If you need anything else, go ahead and press that red button. Okay, my skill is done. What did I do? What did I do? I cootied up. Now, do I want to take this patient's cooties to the next patient or out to the hallway where they have cookies because a family member brought us cookies? Right? When you leave that patient environment, you got to leave all their cooties behind. Veronica, good morning. I passed the test September 4th. Thank you for preparing me again. Thank you. Congratulations, Veronica. Great job. So proud. All right. So any questions on the closing? So we know skill rules. Our care plan tells us what to do. Now, from now on, the review is going to be way shorter than this. Okay. I'm just going to go through the principles. But today, we just wanted to expand on what we learned on Monday with these three. Okay. So our care plan tells us what to do. Our opening tells us how to start every skill, and our closing tells us how to end every skill. And those three things are going to make up about half of the checkpoints for every skill you perform on the test. We haven't even talked about skills yet. But if you do these three things, you will get half of the checklist checked off before we ever even learn about skills. Make sense? Good? All right. Okay, so we've mastered these three principles. Now we're going to move on. These are all the ones we have to learn moving forward. So right now we've got this one, and this one out of the way. We still have to go over these. Now we're going to do it in a very logical, linear order because I'm very, very organized and I build as we go. And we're going to learn three new principles today. But let's talk just a minute about hand sanitizer. Remember that we have to wash our hands during the opening before we touch the patient. We have to wash our hands during the closing after we've touched the patient. And again, after we document, right? We have to do that. But hand sanitizer can also be used in some settings with some patients. Now, you're going to go by your facility guidelines as to hand sanitizer. But let me talk to you a little bit about hand sanitizer. This is Jeremy. This is where I keep my hand sanitizer. But hand sanitizer has some benefits to hand washing, but there's also some drawbacks. So we have to talk about why one might be preferred over another. When you go wash your hands, you wet them, you apply soap, you rub them together for at least 20 seconds, covering all surfaces, you rinse, and then you dry. Where did those germs go? Yeah, actually down the drain, right? Because they got frictioned off, right? We've rubbed our hands together, used water. Now they're completely off my hands in the drain. Make sense? It's not 100%, but it's, for our purposes, our hands are clean. Good morning. When I use hand sanitizer and I rub my hands together, where did those pathogens go? They're still on my hands. They may be dead, but they're still there. Now, I don't know about you, but when I'm eating my fries, a side of dead E. coli is no more appetizing than a side of live E. coli, right? So if we are going to eat, we probably need to do something other than use a hand sanitizer. We want the pathogens off of our hands, not just killed and remaining on our hands. So if you are going to eat, drink, smoke, or use the restroom, you want to wash your hands, not rely on hand sanitizer. Make sense? Good. But the problem with hand sanitizer is we don't use it properly. That's the number one problem. Now, there's some benefits to hand sanitizer because it actually breaks down the membrane of the pathogen. It actually like goes in and pops the bubble, and all the insides just get gooey and they fall apart. So there are some benefits to hand sanitizer because it absolutely demolishes your pathogen. Yay, great job. Hand washing, the pathogens stay intact. We just wash them down the sink. So there's pros and cons to both, right? Hand washing removes the pathogens, but it doesn't really kill them. Hand sanitizer kills the pathogens, but it doesn't really remove them. There's no perfect solution. Now, there is antibacterial soap, but it doesn't do anything for viruses. It doesn't kill the virus membrane. All right, so you guys understand that there's some benefits to both. This is why you have to go by your facility policy. But when you're using hand sanitizer, normally we get a little bit like this, do this, and we're done. In order for this hand sanitizer to be effective and actually break down that membrane, we have to keep our hands wet with sanitizer for at least 20 seconds. Where did we hear that before? Hand washing. So it is not the time saver you think it is. So I have to get enough, and when I say enough, I mean enough to keep my hands wet for at least 20 seconds. And I've got to rub all surfaces just like I did with hand washing. So the backs of the hands, around the wrist, the back of the hands between the fingers, in between my thumb and index finger, the bottom of my finger, my hand by my pinky. All of those areas have to be wet and used friction for at least 20 seconds. It's not the time saver you think it is. If you're just using a little squirt doing this and you're done, you did not kill the pathogens. Now, that can be a problem for our patients because any pathogens that survive can develop immunity. That's not good. That means that whatever we try to throw at it later, it may not react to. Okay, good. So, hand sanitizer will be used in some settings because it does break down the envelope. Hand washing will be asked for in some settings because that's what the patient needs. But there's two specific situations where we have to wash our hands. We cannot use hand sanitizer. And that is when we are working with norovirus and C. diff. So norovirus is called the cruise ship disease or the daycare disease. It spreads very quickly in close confined circumstances, especially when there's body fluids involved. So daycares, this spreads like wildfire because little kids don't keep their body fluids to themselves. They spread them all around everywhere. So norovirus spreads pretty quick in daycares. It also spreads pretty quick on cruise ships because for some reason, when people go on vacation, they think they leave their pathogens at home and they don't adhere to infection control principles. Now, I'm a huge cruiser. I've been on about 35 cruises. I love cruising. And when COVID hit, something very interesting happened. All the cruise ships shut down, went out into the middle of the ocean, and just stayed there for months. Nobody on, nobody off. It just stayed in place. Well, during that time, since they weren't taking passengers, they did a few upgrades along the way. Now, COVID taught us all that we should be washing our hands much more frequently than we were. And COVID was really big on hand washing, hand washing, hand washing. So the cruise ship said, let's make it convenient for people to wash their hands. So they put in these little hand washing stations near most of the restaurants. So you can actually physically wash your hands before you went into the restaurant. Great idea. Because before that, I was having to go find a bathroom to wash my hands before I went to eat. So when cruising resumed, I actually, because I'm me, parked myself at a little booth in front of the buffet. And I watched how many people went in and walked right by that hand washing station, did not wash their hands, did not use hand sanitizer, and then touched all of those utensils on the buffet to scoop the food onto their plate. And then went and found a table and ate the food. And usually that involved, you know, pizza and things that you pick up with your hands and eat, dinner rolls and such. What are they eating? Yeah, all the pathogens, not just theirs, but everybody else's. Have a good day. So what does that mean? Why do we care? Well, remember I said that norovirus spreads in close proximity to other people, especially when there's body fluids involved. So on the cruise ship, there are body fluids everywhere. You don't think about it that way, but there are. So norovirus, if it gets on the cruise ship, it's going to take out about a third of the people. Now, what is norovirus? What does it do? It makes you sick. Everything that you have ever thought about eating in the last week is going to come out both sides. It's going to last for about 3 days, and it's going to make you wish that you were dead. It's awful. It's horrible, but it spreads pretty quickly. It is also not killed by hand sanitizer. Hand washing, getting it down the drain, is the only way to treat norovirus. So if we're working in a clinical setting with a patient with norovirus, should we be using hand sanitizer? That will be on the care plan for that patient. Now, if you think norovirus is bad, and it's bad, let me introduce you to its older, bigger, badder cousin, C. diff. Having everything come out of both ends for 3 days, that sounds awful, right? Not a way I want to spend my weekend. Well, C. diff is 6 to 8 weeks of that. C. diff kills patients, not because the pathogen is so bad, it's because it depletes the patient. There's nothing left. 6 to 8 weeks of this. It is awful, and it's deadly. And it, like norovirus, is not killed by hand sanitizer. So if your care plan says no hand sanitizer, you're probably dealing with one of these two. And that means you've really got to take special precautions not to bring that home, because both of these are not just relegated to the old or the sick. Healthy people get norovirus. Healthy people can get C. diff. Young people get norovirus and C. diff. This can kill you. And if you take it home to your family and you've got little kids, this can be particularly difficult. Or if you've got an elderly person like your grandparents that you're visiting that don't have good immune systems, we can spread this around a community pretty quickly. Good. So this is something that most healthcare workers don't really stop to think about. As a healthcare worker, you are the link between those really big bad pathogens that are bad enough to make somebody be in our institution and the outside world. You are the link there. Anybody ever go to a nursing home and just walk around seeing patients for fun? No. You only go to the nursing home to visit your relatives, right? So, and probably not very often, if ever. So most patients don't have a lot of traffic in and out. The only people in and out are the facility workers. We are the link between the patient's pathogens and the outside world. You ever go into your local grocery store and see people like me walking around in scrubs doing grocery shopping? Is it possible that they are bringing facility pathogens into that grocery store? And you probably never thought about it. Everywhere you go after your work is done, you are taking all of your work pathogens too. So the industry invented something called a scrub jacket, like what you're wearing. A scrub jacket is not a fashion accessory. It is not there for warmth. It is there to put on after your shift is over to cover up your uniform so those pathogens don't get spread around. Good? Make sense? Ethan asks, okay, so does nursing homes norovirus, if it does, will spread everywhere, right? Yes, norovirus can be found in nursing homes, absolutely. And yes, it can spread very quickly, very easily. So we want to make sure that we're using really good hand washing and that we're not going anywhere after we leave work. We go home, we take our scrubs off, we throw them in the washing machine, and we take our showers before we go back out to the grocery store. Good? Questions?
How often should we be cleaning our cars?
So we're going to learn this in just like 15 minutes. But pathogens don't live long on surfaces outside of the body. They don't do well homeless. We'll talk about that in just a minute. So your car, pretty safe because it gets really hot here in Florida, like really hot. And pathogens don't do well in super hot or super cold environments. Now, we do have something, before anybody yells at me on YouTube, we do have some pathogens that are called extremophobes that can live in like volcano vents way under the ocean. And those are extremes. Those aren't the ones we're working with, right? We're working with human grade pathogens, and they usually have to maintain a very specific temperature range. So our car is pretty safe because we bake them in Florida.
So, like, is it fine if we, because you said throw them in the wash,
Mhm.
is it fine if we throw them in, like, the hamper?
Yeah, I mean, as long as you're not going to pull anything out and rewear it, you know. So let me give you an example. When I'm working in a clinical setting, I just throw all of my uniforms in one hamper. I take them all out and I wash all of my uniforms together without anything else. Now, when I was a brand new nurse, I'm talking just like it was the late 80s, brand new nurse. And this is when HIV was first on the scene, right? So I started out in purchasing, and then I worked in sterile processing. Then I had to get my CNA to work in sterile processing, and then I went on for nursing, became an LPN. So during that time, it's late 80s, early 90s, HIV was a really big deal. And one of my first jobs as a new nurse was working with HIV patients. And I had a small child at home. I was very meticulous with infection control because we didn't know much about the virus at the time. We weren't real sure. And I had a small child, and small children do not have good immune systems. So in that situation, I didn't even go into my home with scrubs on. I went into my garage, I stripped. Everything went right into the washer, super hot water, color safe bleach. And I went straight into the shower, washed my hair every day. Because if I've got any pathogens, I don't want to spread them to a child that doesn't have a good working immune system. Now, later on, I went to work in a nursing home and a hospital, and those pathogens weren't as severe as HIV. We knew their method of transmission. We were a little bit more comfortable. So in that case, I didn't have to take those steps. I would just throw all of my scrubs in one hamper, wash them all once a week, and, you know, kind of deal with them a little bit more normally. Does that make sense? So the reason I say that is because it depends on what you're dealing with, you know, the pathogens you're working with. Okay. Yeah. So you're what we call Walmart germs, garden variety germs, as long as you're not working with anything super like norovirus or C. diff or anything that's like super, super transmissible, you're probably fine doing that. But if you're working with something that's super transmissible, I would take those extra steps.
So, if you know you're sick, you get sick, you should not show up to work, right? 100%.
You are absolutely correct. 100%. However, I have to say this. Your employer doesn't care. Your employer has no vested interest in you keeping your patients safe. Right? It goes against everything we're being taught, right? But your employer, because most settings are for profit, healthcare is for profit. Your employer, their entire obligation is to their shareholders. not to the patients. The patients are a commodity. They're just a way of making money. Just like Target is a way of making money. Pizza store is a way of making money, right? The way you make money doesn't matter. It's the money you make that matters when you're for profit. That's their obligation. So, is it in their best interest for these patients to get better and go home? No, because the longer they're there, the more money. So your employer has no vested interest in keeping your patient safe. So the minute you realize that, you'll understand the decisions that they make, because those decisions are going to impact your daily work. I wish it was different. I don't think that healthcare should be for profit. I also don't think that healthcare should be inaccessible, not in a first world country. But that's a whole nother situation that I'm not going to get into here. Okay, I am a capitalist. I own my own business. I've owned multiple businesses. I am a capitalist, but there are some things that should not be subject to capitalism. Human rights. But anyway, that's ethics. So when you are sick, your mindset is keeping your patients safe because that's what you've been trained. That's the role that you're playing. It's not your employer's role. So when you call in and you say, hey, I'm sick, I can't come in, they're going to say, I don't care, come in. We have to have somebody to take care of these patients because they're protecting their ability to make the money. So should you go to work? No. Will you have to? Yes. That's the simple reality of it. Now, if I ever own a nursing home, if I ever run a nursing home, doesn't look good in my lifetime, I'm getting old, but if I ever ran a nursing home, I would only hire the people that I train, and I would run it in a way that benefited the patient, not the shareholders. The problem is that you're not going to get a whole lot of people to invest if you're not looking out for their economic interests, right? So how am I going to get the money to have a nursing home if nobody wants to give me money because I'm not going to make them money with that money? You see how this is going to be a very difficult line for your facilities to walk?
Okay, so this is kind of a stupid question, but you got me thinking for a second. Have there been like nursing homes and like hospitals that purposely get people sick to get more money?
Yeah, proving that would be very, very difficult. Okay. I think it probably happens accidentally much, much, much more often. But I can't tell you that there aren't situations that aren't nefarious. For instance, there was a dentist about 10 years ago who actively infected over, I think it was like 200 of his patients with hepatitis because he had hepatitis and did not use infection control procedures. And it came out during the trial that he was very angry over the fact that he had contracted hepatitis and decided that he would just spread it around because he was mad. You know, so can I tell? Now, this is a dentist, right? This is somebody who went through 12 years of schooling. I mean, this is somebody who should not be making those mental decisions, right? But can I tell you that everybody in healthcare is altruistic and will never make a nefarious decision? No, I can't. I can't. So have there been situations? Yeah, probably. But you're not going to get anybody to admit to it because that's jail time.
So it works the other way too, pushing them out fast
Yeah.
when things stop coming.
Yeah. Yeah, remember that, you know, it's a for-profit facility. If you don't have any money, why am I keeping you here? It's just like an apartment. You know, you might lose your job. You might have an apartment and you've got a year-long contract on that apartment. And in month 6, you lose your job. And now you can't afford the apartment. If you go to the apartment manager and say, hey, I can't afford the apartment, they're going to say, well, you better figure it out because we're not running a charity here. And if you leave that apartment, do they forgive that 6 months? No, you're on the hook for that too. Even though you don't get to live there anymore, you're still paying it, right? So facilities are the same way. If you can't afford to be in a facility, they're not going to let you stay out of the kindness of their hearts. They're going to kick you out. This is happening right now, guys. Right now. There are nursing homes because of all of these budget cuts that just occurred. There are nursing homes. They are kicking out bed-bound old people. These aren't people that can go to work. They are bed-bound. They are comatose. They are unresponsive. And the facility is saying, yeah, we can't keep you. There's nowhere for them to go. They are functionally homeless. And this is a crisis right now. Social workers trying to find a place for these people. They can't go home. There is no home. Where do they go? So yeah, that does happen. And it's happening a whole lot more now because of budget cuts. Scary. Scary. All right, Jay, go ahead and throw it up. Thank you. What is HIV? HIV is human immunodeficiency virus. Immunodeficiency virus, HIV. It's the virus that causes AIDS. All right. All right. Oh, thank you, Jake. Okay, so now we're going to get into our very first skill. Now that we got all of that out of the way, we're going to get into our very first skill. And the very first skill that we're going to learn is pulse. Now, if you remember on Monday, I told you this is the most failed skill on the state exam. Not because it's hard. It's ridiculously easy. It is failed because people don't follow the care plan. So if you look on page 52, you're going to see an overview of this particular skill. Down the side, you'll see the principles that are involved. And right here, you'll see them all spelled out for us. So we're going to follow the care plan. We're going to do our opening. We're going to evaluate if we need gloves, which we're going to get to in a minute. And we're going to do our closing. Those are the principles that are involved in this particular skill, along with the skill-specific steps we need to know that only apply to this skill. I have a video for this. You can see the video clapboard there. And down at the bottom, you can see test-specific information. Somebody with your level of experience skill in 5 minutes or less. This is going to be done on another live testing student, so you might be a patient for this. That person will be laying in bed for this skill. Good. Documentation is required for this. Anything you count, you have to write down. We don't do busy work in healthcare. There is no time for busy work. If I ask you to do something, it's because I need that done, not because I'm trying to keep you busy. So if I ask you, please go get the pulse, and you go take the pulse because you're a good CNA. You do what you were asked to do, but you don't write it down anywhere. It's stuck up in your head. Does that help me? No. I'm good, but I'm not a mind reader. So if you count something and you don't write it down, it doesn't count. Because the people that need that information don't have it. Good? Make sense? So this is a documentation skill. Normal pulse rate is between 60 and 100. That's normal. That's what we're hoping for. Okay? Between 60 and 100. But for the test, you can be off by 4 beats in either direction. That's what you see here where it says variance. You can be off by 4 beats in either direction. So during the test, the evaluator is going to be on one side of the patient taking the pulse. You're going to be on the other side of the patient taking the pulse. You're going to let the evaluator know when you start counting and when you stop counting so they can make sure it's the full minute. And they're going to count during that same time frame. So when you say start and you start counting, they're going to start counting too. When you say stop and you stop counting, they're going to stop counting too. And hopefully you'll get close to the same number. Now you can be 4 beats off in either direction. So let's say the evaluator got 76. If you got 72, 73, 74, 75, 76, 77, 78, 79, or 80, you're within that variance. That's a huge margin of error, guys. Huge margin of error. It's not about being correct. It's about knowing the correct steps.
Whenever we're counting pulse rate test, should we go over by like counting?
No, it should be 1 minute. Whatever you feel in that 1 minute. So we're going to get to how to do this in just a minute. No, because it tells us to count for 1 minute. That means 1 minute, not 1 minute and 1 second. It's 1 minute. Okay, good. Any questions so far? I'm going to show you how to do the skill in a few minutes. But before I do that, we have to talk a little bit about the principles that are involved in this skill. If you go to page 53, at the top of the page, you're going to see the care plan. We know we have to follow the care plan. So if we look at that care plan, it tells us patient will be lying in bed for skill, take the patient's radial pulse measured at the wrist for 1 full minute and record your readings. That's our care plan. That's what it's going to say for the test. So your patient's lying in bed. We're going to use the radial pulse. It even tells us where, located at the wrist. It tells us how long, 1 full minute. So how long are we counting? Where are we counting? At the wrist. As long as you do that, and you do your opening, and you do your closing, you will pass. It's that simple. Find the pulse at the wrist, count for 1 full minute, do your opening, do your closing, make sure you document. You will pass this. It doesn't matter what number you get. It does not matter what number you get. You will pass. You won't be perfect, but you will pass. It's not about how accurate you are. It's how you do the skill, how accurate the steps are. Good? Because they know that as long as you're doing the steps right, you'll get better with practice. Your accuracy will improve. But if your steps are wrong, no amount of practice is going to help you because you're always practicing wrong. You starting to see how the test is structured? You guys as students focus on the wrong thing. As students, you want to get everything absolutely perfect because you think that's how they're going to grade you. That's not what it's about. The test is focusing on the patient, not you. Every step you miss has an effect on this patient. What is that effect? That's what the test is looking at. Okay, good? Good. All right. Step-by-step instructions are there. You can see the documentation sheet in the second column. We'll get there in a little while. Your supplies are at the bottom. But before we actually get into the skill itself, how to do this skill, okay? This is our care plan. Our care plan tells us patient will be lying in bed for skill. Take the patient's radial pulse, measured at the wrist for 1 full minute, record your readings. Down here are your principles that are going to be involved in the skill. Over here is skill-specific steps that we're going to go over. But if you look at this list of principles, you can see that we don't know one of them. We do know skill rules. We do know the opening, and we do know the closing. I know that because we just went over them. Over the last hour, we covered these. So we don't know glove rules, though. So that's what we're going to learn first, since that tells us how to do this skill. So if you look in your book on page 40, we're going to learn about gloves. And I'm going to challenge everything you think you know. Glove rules apply to every single skill. You do not wear gloves for every single skill, but you do have to evaluate if you need gloves for every single skill. And that's because the gloves actually aren't skill-based. They're patient-based. I'm going to get to that in just a few minutes. But a question I get asked a lot is, well, which skills do I need gloves for? And the answer is, well, because it depends on the patient that you're doing the skill on, not the skill itself. Good? Make sense? All right. I have a video on this. I'm not going to show you the video in class, but you can go watch that video on your own if you want to. It'll be in the email, the wrap-up email. How many of you guys got the wrap-up email from Monday? Okay, good. All right. If you didn't, make sure Jake knows. If in there will be the links to all the videos. All right, this is one of the big four. So these four apply to every single skill we learn to do. We have our skill rules opening, glove rules, and closing. That's the big four. And, excuse me, our notes are on page 41. But in order to understand when gloves are supposed to be used and when we don't need them, we're going to talk about infection control. And the best way for me to illustrate this has nothing to do with healthcare. We're going to build a sandwich. Have you ever gone to a place where they build a sandwich in front of you? You tell them what you want and they make the sandwich, right? Those are always good sandwiches. We're going to do that together in class. And when we're building our sandwich, of course, we want the worker to wear gloves because we don't want them to touch our food, right? It's pretty important. I always look to make sure, are they wearing gloves? I don't want them to touch my food with where have their hands been? But we've talked about all the things you touch with your hands. We don't want that on our sandwich. So we take a look and they're wearing gloves and we're good to go. All right, what's your name? Right here in front. What's your name?
Oh, Finley.
Finley. Okay, so Finley, I'm going to start with you. This is an interactive exercise. We're going to build the sandwich together. So Finley, I now have my gloves on. What kind of bread do we want? White. So I'm going to go into that bread cart and I'm going to get a loaf of white bread and I'm going to put it on the counter. And then I'm going to pick up the knife and I'm going to slice it in half and open it up and kind of smush it down so I can put the condiments on it. Okay, so now that I've got my bread cut and ready, what do we want? Some mayonnaise on there? So I'm going to reach in, and that mayonnaise always has that spreader thing sticking out of it. So I'm going to grab that spreader thing, get some mayonnaise, and I'm going to put it on my bread, put the spreader thing back in for the next sandwich. Do we want any other sauces like mustard or honey mustard or chipotle or sweet chili? So I'm going to reach over here and grab a sauce container and tap it and squirt some sweet chili on there. All right, we'll put that back. So what kind of meat do we want? Okay, well, we're not there yet. So what kind of meat do you want?
Turkey.
Turkey. So I'm going to open up the refrigerator and I'm going to get the turkey out and close the refrigerator and put the turkey on the sandwich. What kind of cheese do we want?
Provolone.
Provolone. Uh-oh. Okay. Oh, we always want bacon. Bacon's good on a sandwich. So I'm going to get some bacon out of the package. And once we get, see, I'm not keeping up here. Once we get our meat on there, I need some cheese, but my cheese drawer doesn't have any provolone. I'm out. So I'm going to go into this big walk-in cooler, you know, that they have, and I'm going to get into one of those containers and get the provolone out, but we have to slice it. So I'm going to put it on the slicer and we're going to slice the cheese. I'm going to put the provolone back in the walk-in cooler and bring the cheese over and put some cheese on the sandwich. All right, now that we have some cheese, do we want this toasted? Okay, so we have to wait for that toaster because it's always busy. So I noticed that her hands were just kind of resting on the table while she was waiting for that toaster. And then it's our turn. So she puts the sandwich in and she turns the little dial and she's holding on to the toaster handle. And then once it's toasted, she gets that paddle thing to pull the sandwich out. Okay, so now we've got it on our table and we're ready to go. Lettuce. So I'm going to reach into the lettuce bin, grab a thing of lettuce, and we're going to spread that on the sandwich. How about some tomato? No tomato? Okay. What about some pickles? Pickles. So I'm going to reach into the pickles. We got to squeeze those out pretty good, right? And we're going to put the pickles on here. What about black olives? I'm going to get some black olives and put those on. Onions, peppers, nothing like that. Okay. How about salt and vinegar? So I'm going to get the salt shaker and shake it and the vinegar. Okay, so now we're going to take that knife and shove it in there because I got a lot of toppings on there and fold that over and pull the knife out and put it down for the next sandwich. And then I'm going to wrap up that sandwich in a wrapper and go over to some sort of a display and we're going to type it in. and I'm going to hand it to you, and you now are able to eat the sandwich. How many of you guys want to eat the sandwich? Why?
Never change your gloves.
Okay, but you were perfectly happy with that before 5 minutes ago. You wanted me to wear gloves at the beginning. You guys were all nodding at me. You wanted me to wear gloves at the beginning of this. It's only been 5 minutes. What changed?
We didn't have any tongs in each container.
It was all a mess.
Didn't expect them to touch everything.
Everything was a disaster.
Rather change the gloves on purpose.
You don't eat the sandwiches anymore, I gather.
No, actually, I took all of those pictures. That was a sandwich that I ordered. And it was last year at Thanksgiving time, because they have an amazing, don't say it out loud, but you guys know where this was, that they have an amazing cranberry toasted sandwich. It's amazing. And that was my sub, and I ate it. I took all those pictures on purpose for this display, and I ate that sandwich. Why did I eat? Now, y'all are looking at me like, whoa, wait, yeah, she just touched everything, and that sandwich is not clean. No, it's not clean. And that's okay, because I'm healthy, and my immune system needs a little bit of a workout every day to stay healthy. If you sit on your couch and you don't get up and exercise, what happens to your muscles? They start to deteriorate. They get weak. They get flabby, right? Because they're not being exercised. They're not being used. The same thing happens to your immune system. If you don't use your immune system on a regular basis, it gets flabby, out of shape. This is why you do not want to put your kids in a protective bubble. They have to have some sort of an immune workout. Now, thankfully, all they're coming into contact with is Walmart variety germs, but it allows their immune system to slowly develop over time, so that when they're older, they can eat a sandwich from this place and be perfectly okay. Good? Make sense? All right. So we all look at this now differently than we looked at it 5 minutes ago, because 5 minutes ago, we wanted them to wear gloves because we didn't want their hands to touch the sandwich. Now we're looking at those gloves going, wait a minute, what did those gloves actually touch? And let's take a look at what those gloves actually touched. It touched the outside of the bread cart, the knife, the mayonnaise spreader, the sauce bottles, the outside of the bacon package, the cheese drawer, the door handle, the containers inside the cooler, the slicing machine, the table, the toaster oven controls, the paddle, the lettuce, tomato, and other toppings, and the wrapper. I mean, we touched a lot of things with those gloves. So, are those gloves clean? No. Did those gloves do what you thought they were doing? No. It's really no different than them touching your sandwich with bare hands. Right? Those gloves didn't do what you thought they were doing. Now, this is important, because in healthcare, those gloves are not doing what you think that they're doing. Good? Make sense? I find that that's a very useful analogy for you guys to see. And don't stop eating sandwiches. They're fine. Okay. All right. So in order to understand if gloves are effective, we have to think about who they're there to protect. And those gloves actually have to do more than you think they do, because you as a healthcare worker are thinking that those gloves are there to protect you. You don't want the germs the patient has. You know they came in with germs. You don't want those. But we have to think in this situation about who those gloves really need to be protecting. So in healthcare, we work in a very unique situation. We are intentionally going to a place that we know that there's pathogens, right? We work in hospitals and surgical centers and rehabs and nursing homes and same-day surgeries and walk-in clinics and hospice and home health. I mean, we work in a lot of different places, a lot of different types of pathogens. And in order to understand that, we have to learn about something called the chain of infection. So this is going to be in your book on page 123. And this could be on the written exam, the chain of infection. In fact, it's likely to be on the written exam. All right, so the chain of infection centers around this graphic. This tells us how a pathogen gets from infecting one person to infecting another. And it's very, very, very well defined steps. There's 6 of them. And if we can interrupt this journey anywhere in this 6-step process, we will prevent an infection from being spread. So we've got 6 chances here. That's pretty good odds. 6 chances to derail this pathogen. It's not automatic. Okay? So let's take a look at all 6 of these steps. First, you got to have a pathogen. No pathogen, no problem. If I do not have the HIV virus, I cannot give it to you. I simply don't have it. I am not a risk factor, right? So no pathogen, no problem. If you can get rid of the pathogen, hey, that's a perfect world, isn't it? If we could get rid of, totally wipe out polio, nobody would get polio. Make sense? Right? So our goal with infections is to wipe out the pathogen. But in most cases, that's just not realistic. It's not feasible. There's just too many of them. You know, it's really hard to wipe something out. But remember, no pathogen, no problem. Now, if we have a pathogen, though, that pathogen has to have a place to live. They do not do well homeless. It's like me. I would not do well. I am a person of creature comforts, right? You put me in the woods in a sleeping bag, I'm probably not going to make it. So they have to have a nice, warm, comfortable place to live. And the ideal nice, warm, comfortable place to live is a body. That is like the ideal place. It's fully furnished. It comes with an open bar. It's nice and comfy. They don't want to leave. Okay. In fact, they're so comfortable in that body that they kind of have to be forced out because they're comfortable there. So a pathogen has to have a reservoir or a host to live. Pathogens outside of that environment don't live very long. Every pathogen has a little bit different amount of time that it can survive outside of the body, but on average, you're talking about minutes to hours. That's it. That's it. So if this patient gets body fluids on this bed and I come in a day later, all of the pathogens in that body fluid, they're all dead. Can't live. Good? Makes sense? Okay. All right. So they have to have a nice, warm, comfy place to live called a host or a reservoir. And they're happy there. In fact, to get them to leave requires force in most cases. They don't want to leave. They got everything they need. They're like teenagers. Don't want to leave. Okay. So in most cases, you're going to see this in the pathogens leaving the body under force. So let me give you some examples. If you've ever had a respiratory infection where you got sick, what does it make you do? What are your symptoms? Cough. Let's talk about that. So a cough is actually not the pathogen. The cough is your body. Your body recognizes, hey, we got these pathogens in the lungs and the trachea and the nose and this area. We want to get rid of them. We want to force them out. So the best way to force them out is to push them out with a cough. A cough is your body's way of trying to eject the pathogens. What else? What other symptoms?
Runny nose.
Runny nose, same thing. your upper respiratory says, hey, pathogens, you don't belong, floods the gates to drown the pathogens, and they run down your face. Runny nose. What else? Sore throat. So your body actually sends white blood cells to the area. It puffs up that area so that, because we have way more white blood cells there, and it makes it all bumpy so those pathogens don't, the environment is not as comfy. What else? Fever. Remember I said these have a very narrow window? If it gets too cold or too hot, they're not happy. A fever is your body's way of making it too hot for them. So they want to leave. So you're starting to see that your cold symptoms actually are your body's reaction. It's not the virus that's causing the symptoms. It's your body's reaction to the virus. So now you got to think to yourself, well, okay, if my symptoms are caused by my body, then what is the virus actually doing? Right? If the virus isn't causing these things, why would my body react that way? What is the virus doing? So let's talk a little bit about viruses. A virus has one job, and it's not to make you sick. That is not what a virus is there to do. A virus's one job is to invade a cell and make copies of itself. That's its only job. It's all a virus will ever do. It finds a cell, invades it, and turns on a copy machine to make copies of itself. Now, the type of cell that it has to use for that will vary depending on the virus. So hepatitis, remember we talked about that a little while ago? Hepatitis uses liver cells. That word hepato means liver. So hepatitis means the virus invades the liver cells, takes it over, and becomes a copy machine. Now, inside your cells, you have DNA. That DNA tells the cell who to be and what to do. The virus unzips the DNA into its two halves, takes one of the halves and plugs itself in, and that's where the copy machine comes in. So now that cell can't do what it was originally intended to do because the DNA has been ripped in half. It's not going to work like a liver cell anymore. It's now simply a copy machine. So we have one cell, one little liver cell, just one, that's not acting like a liver cell. That's not a big deal. But as that cell creates more copies of the virus, the cell is going to burst, and all of those little copies are going to go around and infect other liver cells. Now, those liver cells are not being liver cells anymore. They turn into copy machines. And eventually we get to the point that none of the liver cells are doing the liver job. Is that a problem? That is the danger of a virus. A virus is not causing your runny nose, your cough, your fever. That is your body's reaction to the virus to get it out of there, because your body knows that that virus has hijacked some cells, and those cells are not doing the things the cells should be doing. So we've got to get the virus out. Does that make sense? Now, different viruses infect different cells. So let's talk about HIV. So HIV was the human immunodeficiency virus, or the virus that causes AIDS. The cell HIV uses as a copy machine is some of your white blood cells, your immune cells. So it's doubly dangerous because it is hijacking the very cells that are supposed to kill it. Okay, so that's why HIV is doubly dangerous, because not only does it just interfere with the regular workings of it, it intentionally goes out and targets the cells that are trying. It's like an invading army just turning all the other army people into its own soldiers.
So the temperature is, you said it helps to kill the virus. So how come everyone's first reaction is to get your temperature back down?
So very good question. So now we know, right? Just like the sandwich, right? Before 5 minutes ago, you thought you knew what gloves were for, right? You thought that was a good idea. So when you get sick and you start coughing and sneezing, runny nose, sore throat, mild fever, you go run for the medicine cabinet and you take things to stop those symptoms to make yourself feel better, right? What you've done is you've turned off your immune system. So, I mean, your immune system is still working in the background. It will eventually clear the virus. It will eventually, but you're working against it. And it's all because we don't like to feel bad. When you go to the doctor and you pay your copay, probably $50, $90 now, whatever your copay is, you expect to leave there with something to make you feel better. That's your expectation. If you walked into a doctor's office and you said, hey, doc, I don't feel good. I got this cold. And doc says, yeah, just go home, lay on the couch for the next 2 weeks, lots of vitamin C, orange juice, let your body fight it. Don't take anything. You can be happy that you spent that $50? No. And you're probably going to go on to Google reviews and you're going to leave them a 1-star review and nobody's going to want to go. And right, this is going to have long range consequences because you didn't get what you wanted. So the doctor's going to, if you pay the copay and you go in, the doctor's going to give you some sort of prescription. Does it mean that it's actually in your best interest? No. As long as the fever is not over 100, 100.5, we shouldn't treat it. You should let your body do what it's trying to do. Now, once it gets over about 100.5 or 101, now we have to look at treating it because we don't want to boil your brain. Okay. So sometimes your body means well, but it kind of goes a little too far, right? So that's what that is. So we shouldn't really think about treating the fever in a perfect world. Now, this does change with immunocompromising patients and that type of thing. But in a perfect world, we should let our body do what it's supposed to do and watch it to make sure that the symptoms are getting too bad where it's counterproductive.
Breaking a fever is your body's way of saying, okay, I fought everything off. Now we're getting back to normal.
So it could be a couple of different things. Your body can only tolerate a sustained temperature for so long before it just kind of gives up, because in order to make that heat, your body has to burn resources. And once it's out of resources to burn, it's like firewood, right? When you go through all of the stack of firewood in your fireplace and there's no more wood, the fire is going to go out. So your body can't just create heat out of nothing. It's got to burn something to create that heat. We're going to get into that in a future lesson. So breaking the fever could be that we just ran out of things to burn, or it could be that the viral load is low enough now that we don't have to employ that particular strategy. Or it could just be that, the body is tired and we've got to conserve some resources. So there's a couple different reasons that the fever can break.
Doesn't taking certain meds also reduce effectiveness?
It could hamper your immune response. Yeah. I like to be comfortable. I am a comfort-based person, right? But I also know that if I'm getting symptoms of a cold, unless it's affecting my sleep, now I need rest to get better. Sleep is where your body actually heals. I know I need rest. So if I'm up coughing and hacking all night and I'm not getting any rest, that's not helping my body. So taking cold medicine at night when I'm sleeping might be a really good idea, especially if my symptoms are keeping me up. Good? Make sense? Okay. All right. So if we've got a pathogen and they have a comfy place to live, a host or a reservoir, they have to have a doorway out. Pathogens do not drill through the skin. They can't drill out, they can't drill in, they can't get through the skin at all. They've got to have a way out. So let's talk about what we were just discussing. Runny nose, that's a doorway out. Coughing, that's a doorway out. If we have a cut and we're bleeding, that's a doorway out. Our genital area, our urinary tract, our bowel tract, those are all doorways out. Okay. Pathogens can't get through the skin. They have to have a doorway to get out. Remember, they have to pretty much be forced out. Good? Okay. These are all called wet body openings. So your eyes, your nose, your mouth, your genitals, your rectal area, those are all wet body openings or doorways that pathogens can use to leave the body. So if we're going to be working around somebody's nose and it's running, there's probably some pathogens there. If we're going to be working around somebody's mouth, we need to know that pathogens can come out through that opening. If we're going to be working around somebody's eyes, we need to know that pathogens can come out of that opening. If we're going to be working around somebody's genital or rectal area, pathogens can come out of those openings. So wet body openings can transmit pathogens. But pathogens themselves, the problem with them is that they don't get around on their own. So we have natural wet body openings, eyes, nose, mouth, genitals, rectal area. But there's also some other wet body openings that aren't necessarily natural, like incisions, wounds, rashes, anywhere where our skin is not intact. Good? Those are all considered wet body openings. And we kind of have to look at them with a little bit of suspicion, because if it's a wet body opening, there could be some pathogens being forced out of it. Make sense? Questions so far? Pathogens don't get around on their own. They don't have wings. They don't have feet. They have no way of getting around on their own. So let's say that I spring a leak. I cut my arm here. I am bleeding. Blood gets onto the table. And let's say that I have hepatitis. So there's blood right here. I've got a cut on my arm. And you over there are not in any danger, because that pathogen can't fly over to you. It can't crawl to, there's no arms, there's no legs, there's cells. They have to travel in something. Good? Make sense? So most of the time they're going to travel in fluid. Pathogens either need to flow or float. And very few pathogens are light enough to float. Most of them are pretty heavy. So they have to flow in body fluids. That's why wet body openings can be dangerous. Or they have to float. Make sense? So we have a pathogen, no problem. It's got to have a place to live, which is a host or a reservoir. And then it has to be forced out. Those are called portals of exit, doorways out. And then once it's out, it's got to have a way of getting around, a mode of transmission. You over there, not an issue. Anything that's going on over here. You guys got that so far? Remember I said there's 6 places that we can interfere with pathogen transfer. No pathogen, no problem. If there's no doorways or we're not working around doorways, no problem. Once a pathogen comes out, as long as we're not near it, no problem. Okay, so there's lots of opportunities for us to interfere here. Good? Questions so far? All right. So let's talk about flow and float. So flow is in some sort of a body fluid, as long as it's liquid. Anything that's dried up, it's not flowing anymore, is it? Not a problem. So anything dried is not going to transmit pathogens. It's got to be liquid. Good so far? All right. So flowing, pretty self-explanatory. As long as you're dealing with wet liquids, there's a possibility of pathogens being in there. We should take some precautions. But floating is something a little different. There are very, very few, less than this many pathogens that can truly float in this entire big blue marble that we live on. That's it. Less than 5. One of them has made the news recently. Measles. Measles is small enough that it stays suspended in the air. So, and with measles, you can or you will shed virus through your respiratory tract just by breathing long before you get symptoms, about 10 days before you get symptoms. So you over there, what's your name? Liz. Liz, you might have measles and we won't know it until the end of next week. But in the meantime, everybody that has breathed the same air that you have breathed has now been exposed to measles for the next 10 days. This is why you're hearing on the news, especially if you're in Texas or have gone to Texas, because that's where the hot spot is right now. Although measles has shown up in other states as well. But on the evening news, they're actually daily saying, okay, if you've been to this grocery store, this airport, this playground, this, you know, they're listing off because remember that it's contractable for about 10 days before you ever know you've got it. That period of time is called an incubation period. Now, measles is very, very, very unique because it is so small that it just stays in the air. You breathe it in and you've now been exposed. Doesn't mean you're going to get measles. It just means you've been exposed. We're going to get to that part in just a minute. You guys following along so far? Okay. There are a few others that are airborne, nothing that we really have to worry about on a day-to-day basis. It's very, very, very rare. But when COVID first hit, the very first days of COVID, we didn't know whether COVID was airborne or not. We didn't know. Remember, I said less than this many are airborne. On this big blue marble that we live on, less than 5 are truly airborne. But with a new pathogen, there's a period of time that we don't know because they don't come with instruction manuals. We got to figure it out. Now, what's much more common than airborne is droplet. Droplet's kind of a type of airborne, but a little bit different. Droplet means that the virus particle itself doesn't stay in the air. It has to hitch a ride on a mucus particle. Now, when I'm talking and breathing and laughing, little itty bitty teeny tiny pieces of saliva come out. Little teeny, I mean, you can't even see them. They're so small. But it's just part of our everyday, you know, as we talk, as we breathe, as we laugh, these little pieces of little droplets come out. And if I have a pathogen that's hitching a ride on some of them, then those droplets can go out a little ways. Now, droplets are heavy. Gravity on planet Earth is going to pull those droplets down, which means that around 6 feet in front of me could be little droplets of that might have pathogens. Do you remember during COVID, after the first couple of weeks, once we realized it wasn't airborne, we told you guys to stand how far away from other people? Oh, interesting. That's the same distance because we realized that COVID is spread through droplet transmission. As long as they're 6 feet, you're not breathing in any of my droplets. This is why I'm over here and you guys are over there because I'm doing all the talking. Good? Makes sense? Questions so far? You learning anything? Okay. So remember I said there's 6 places that we can interfere with this whole process. We have 6 chances of not getting infected with a pathogen. So first, no pathogen, no problem. Second, the pathogen has to have a host or a reservoir. It's not going to live out in the open. Third, it's got to have a way of getting out of the reservoir because it doesn't drill through skin. Fourth, it has to have a way of getting around. Can't fly. It's got to flow or float. Good. But just because I have a pathogen and I have talked and now there's pathogens around me, you're still safe because that pathogen has to get inside of you. So even if you came up here to talk to me and you touched the table and there's wet and then you wiped your eyes, that pathogen has to be able to get inside you. Now, the only way it can get inside is through a portal of entry, which is the same as a portal of exit. So eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, incisions. Same body openings. So remember us talking about the cell phone earlier? You bring the cell phone up here. What is up here? All of those portals of entry. So when you're bringing your phone up to your face, what you're doing is allowing pathogens to have absolute connection with some sort of an entryway into you. Remember, we're working in healthcare. We don't want to allow those pathogens to be able to get inside of us. Good? Questions so far? All right. Now, the last stage in this, I'm not keeping up here. Hold on. I keep forgetting to do this. So the last stage here, remember that pathogens can't drill through the skin. Remember me saying that? They can't drill through the skin? They have to have a doorway that's already there. So a good strategy here is to cover your holes. Cover your holes. If a pathogen can't get into any of your holes, it can't get inside of you. Cover your holes. Good? Makes sense? Okay. All right. So once a pathogen does get into you, so for instance, when I'm talking about covering my holes, what I mean is that if I have a big scratch or incision on my arm, I probably want to cover it so the pathogens don't have an entry point. If I'm going to be working with a patient and I'm going to be super close to them, and I know that they have an infectious disease that's going to be spread by droplets, I'm going to want to cover the holes on my face with a mask and a shield. It's called transmission-based precautions. Means I know they have something. I know how to prevent the spread of that. We're going to cover whatever holes are required. Good? Good. Okay. So once we have a pathogen and they got out, they had a host and they got out of the host and they got somewhere through a mode of transmission and they got inside me through a wet body opening. Now I'm in trouble. I'm still not infected yet, though. I'm in trouble, but I'm not infected yet because my body has to be susceptible to that infection. So what does that mean? Well, what that means is that just because a virus invades doesn't mean that your body can't fight it off before it does damage. Guys, remember me talking about viruses? Their whole goal is to invade a cell and to set up a copy shop, right? So if my white blood cells see that invader and go, oh, hey, you don't belong here. I'm going to kill you before you can invade a cell. Then I am not susceptible. This is the whole basis of your immune system. So your immune system, from the time that white blood cell is born in your bone marrow, that's where white blood cells and red blood cells are born, it's in your bone marrow. When that white blood cell, which is our bodyguards, our invasion killers, when that white blood cell gets created, it has to go to basic training. And in basic training, it learns how to fight different pathogens. And part of that basic training involves telling the white blood cells, okay, you see this guy here? This is the hepatitis virus. This is what it looks like. This is how we kill it. And this is where it hangs out. So on your travels, when we put you into circulation, if you ever see this guy, this is what you need to do. So we give it a list of instructions on how to recognize a pathogen and how to kill it before it starts copying itself. Do you know how we give the body that instruction manual? Okay, so part of it is through vaccines, right? So we can inject instructions. This is what COVID looks like. This is how to recognize it, and this is how to kill it. We can inject that information. But we also gain it through natural immunity. And what natural immunity is, it's the same thing. It's still an instruction manual, exactly the same. It just takes a little bit longer. Because let's say that we've got a whole line of bad guys outside that door. And those bad guys are going to invade. And the first one, the first bad guy that comes in, you don't want him here. So you pick up that hand sanitizer and you just start bashing him over the head. Well, it doesn't kill him. It doesn't kill him. Hey, hand sanitizer isn't going to do a thing. But you did scare him. So he's going to go outside and he's going to tell the next guy, hey, when you run in, good luck. Hope you do better than I did. But when you run in, that girl's going to hit you over the head with a hand sanitizer. So the next pathogen that comes in, they're going to bob and weave and avoid the hand sanitizer. So Finley's going to pick up that coffee cup and dump hot coffee on it. Now, it didn't kill it, did scald it, but didn't kill it. It ran away, scared it, went outside and said, hey, in addition to the hand sanitizer girl, you're going to have a guy that's going to throw coffee at you. Make sure you weave the other way, avoid it. So third pathogen that comes in sees you. You pick up a fire extinguisher and you just squirt foam all on its face. It can't breathe, and we've killed it. So the next time that we see that exact same pathogen, are we going to go for hand sanitizer? Are we going to go for hot coffee? What are we going for? Fire extinguisher, because we know it works. We have an instruction manual now, exactly how to identify and kill that invading pathogen. Makes sense? But that took a long time. And in the meantime, those pathogens were able to invade a cell and set up a copy shop. And that's why you got sick, because your body is fighting the pathogen, trying to figure out what's working, what's not working. So you get sick for a little while. Your body perseveres, it overcomes, you get over the sickness, and now we've got a record. That's natural immunity. So while we're acquiring natural immunity, it's kind of, touch and go, because what if they win? No guarantee, right? Touch and go. If the pathogen wins, it's game over. If they're able to invade enough cells and take over those cells, and those cells can't do what they're supposed to do before your immune system kills it, that's game over. So natural immunity can be risky. Thankfully, most of our pathogens, because we've lived here on this planet through multiple generations, multiple, like thousands of years. So a couple thousand years ago, when a pathogen invaded, you had a much higher chance of dying because you didn't have any inherited immunity. So the people that survived back then were able to pass that instruction manual down to the next generation and the next generation. And then they would add to it and pass that instruction manual down to the next generation. So each generation, the manual gets bigger and bigger and bigger and bigger and bigger. So we have inherited immunity. We have acquired immunity. And then we have immunity that is given via some sort of outside agency, vaccines or something like that. Make sense? So this works with bacteria too. Right now we're just focusing on viruses, but this works for bacteria. And there's a big difference between viruses and bacteria, like huge. Viruses are just little protein envelopes that their whole job is to make copies of themselves. That's it. Bacteria are different. Bacteria are living beings, just like you. Just like you. And bacteria, they don't invade cells and try to make copies. That's not what they do. Bacteria just corrupt whatever's there. It just basically eats whatever's there. Corrupts it. So we have to, because they're two different armies, two different foes, we have to treat them a little bit differently. So with bacteria, we have antibiotics, which just kills the bacteria. We don't have very many antivirals, and they're not all that effective because remember, they're not living. How do you kill something that's not alive? A little harder to do. Good? Makes sense? Okay. All right. Any questions on that? All right. So we've already been through this. I'm just going to go through these real quick. All right. So this is important. Since the pathogens usually travel in fluids, and as long as you are not touching body fluids, you are not at an increased risk. Remember, those pathogens have to be in fluid to be alive. So as long as you are just touching skin, pathogens don't drill through skin. As long as I'm just touching skin, there is no additional threat to me because pathogens don't drill through the skin. Now, if I'm going to touch anything wet, now I might be exposed, but that doesn't mean I'm contaminated. That wet has to get in through a doorway, through a hole of some sort. So in healthcare, do you want to be putting your hands up near your face? And yet we do this all day, every day without thinking. Your hands will always migrate up to your face. Always. I mean, right now, just in this conversation, I have seen about half of you touch your face just since we've been in this conversation. So in healthcare, you need to be aware of this so you can start training your brain not to touch your face. That's where most of our holes, open holes, are. The rest of them are usually covered. Okay. If they're not, you probably took a wrong turn somewhere. Okay. But the ones on your face are, they're kind of a danger to us because our hands just automatically go there quite often. If you have any wounds or rashes or sores or incisions, you need to keep them covered with some sort of a bandage. So everybody understand a little bit more about the chain of infection? So there's lots of ways that we can interfere with this whole process. So even though we're talking about working in healthcare and we're talking about using gloves to protect ourselves while we're working with all these pathogens in healthcare, we have to understand that it takes a lot of work for pathogens to go from you to me. There's a lot of steps that have to occur for me to get sick. Simply performing some sort of care on this patient is not enough. There's a lot of steps that have to happen here. So the biggest thing is don't let stuff from somebody else's holes into any of your holes. Cover your holes. If you can remember that, you will eliminate your chance of being infected. So if you're going to be working with body fluids that might splash, like you're emptying a bedpan into a toilet, we may get some splashing. Would you want your holes uncovered for that? No, you'd want to have something to cover those holes. Make sense? This is called transmission-based precautions and standard precautions. So these are two different things. Standard precautions, let me go. We'll come back to that in a minute. Standard precautions are precautions I take with absolutely everybody because I don't know what pathogens you have. You don't have a little screen on your forehead that says HIV, hepatitis, TB. You don't, it's not displayed anywhere. And for the most part, until you get really, really sick, you don't even look sick. So you might have something that I have no idea. You don't even know you've got it because you don't have symptoms yet. So you can't tell by looking at somebody whether they have a pathogen. You just can't tell. So we use these rules with everybody. Everybody. My oldest son was 17 and got hurt on the job. And he came home to me and I had to clean his wound and dress it. And it was on the top of his foot, like where his foot and ankle came together. Went all the way down to the tendon. It was pretty bad. And as soon as he got there, I put some gloves on and went to clean it. He's like, Mom, I'm your son. Why do you have gloves on? I'm your son. And I said, Doesn't matter. I don't know that you don't have a pathogen. This is my son. I love him dearly, but he was 17 and he had been out of my sight for more than 10 minutes in his entire life. I don't know what he did in those 10 minutes, right? You don't know. You don't know. So you want to, if you're going to touch any wet body openings, you want to have an extra layer of protection, but it's not just there for you. That is a wet body opening. Wet body openings allow pathogens in as well. Make sense? Those gloves do not just protect you. They actually, in most places, are there to protect the patient, not you. You are healthy. You have a good working immune system. You are not currently ill or injured. So if you encounter a pathogen, your immune system has a pretty good chance, some fighting odds. But that patient is already sick. They're already ill or injured. They're already fighting. So if that patient is already fighting something, and we give them a second something, because remember, we're working in a facility that has a lot of different pathogens. They're not all the same. If we give that patient a second something to fight, they may not have the resources to be able to fight a two-front war. And one of them may win. Those gloves are there to protect the patient as well as you. Does that make sense? All right. Have you learned anything about gloves? I'm going to tell you that this class would be so much easier on me if I just told you wear gloves for everything. That's a whole lot easier than going through a 45-minute conversation about gloves, isn't it? If I just said, just wear gloves for everything. But when you do that, when you wear gloves for everything, it's just like that sandwich person. Do you think that sandwich person was aware of everything they touched? When you wear gloves for everything, you stop paying attention to what you're touching with those gloves. And who is that going to put at risk? The patient. And the patient is the one that's really already at risk. Do you guys understand that? So we have to have some rules. We have to have some rules. So remember that pathogens cannot get through the skin. As a CNA, we generally work with a lot of wet body openings. We are doing ADLs, bathing, dressing, grooming, feeding, toileting, right? We are around all kinds of open wet holes as CNAs. We need to understand pathogens can't get through the skin. And if we're going to be touching wet, we probably want an extra layer, not just to protect us, but also to protect the patient. Because remember, that open doorway can let pathogens in, and we're in a pathogen-rich environment. So if we are going to be doing any skills that puts us around wet body openings, then we probably want an extra layer of protection, not just for us, but also for the patient. Good? Any questions on that? Okay. So those gloves are there to protect both parties. But I would argue it's probably more important that we protect the patient. And the reason for that is because we have learned the opening and the closing. So what is the one action that is in both the opening and the closing? Washing our hands. So we are washing our hands before we touch this patient. And then we're touching the patient, doing whatever we need to do with the patient. And then we're washing our hands after we touch the patient. And remember, pathogens cannot drill through the skin. So as long as you don't have your hands up near your face, near any of your body openings, you should not be in contact with any pathogens. Does that make sense? Good. Because when you wash your hands before, you're touching that patient with clean hands. You've got the patient cooties on them, but you're not bringing them anything else. When you wash your hands at the end of the skill, you're washing all of that patient's cooties off. So unless you're around any of your wet body openings, you are not at risk. Make sense? Good. All right. Remember, pathogens need doorways to get out and fluids to travel in. So we have to have some rules here. And our rules are, we're going to use gloves if we might touch body fluids because pathogens travel in body fluids. Personal skin, so anything normally covered by a bathing suit. And non-intact skin, wounds, rashes, sores, and incisions. If we're going to touch any of those three, we need an extra set of gloves, not just to protect us, but to protect the patient. Good? All right. So if we decide to wear gloves because of standard precautions, this applies to everybody, whether it's your 17-year-old kid or your 86-year-old neighbor. If you're going to be around body fluids, personal skin, or non-intact skin, you need a set of gloves. You need an extra layer of protection for you and them. But if we decide that we are going to wear gloves, the first thing those gloves should touch is the patient. Otherwise, we get into our sandwich situation. If we put our gloves on the minute we walk in that door and we touch that privacy curtain and we touch the bed control and we get all of our supplies and we adjust the table and we adjust the bed, we do all of this kind of stuff, and then we take those same gloves that have touched all of those areas and touch our patient's wet body openings, we're probably going to give them something that they don't want. Make sense? So if you're going to touch personal skin, non-intact skin, or body fluids, you need gloves. But if you decide to wear gloves, the first thing they should touch is the patient. Keep your gloves clean for the patient. All right. Remember, doorways let things in as well as out. Now, once you have touched the patient, your gloves are considered contaminated. You've got to pay attention to what else you're touching in the environment so we're not spreading those cooties all over everything. Remember, cooties need fluid, and as long as the fluid is wet, it might potentially have pathogens. So we don't want to touch the bed controller with soiled gloves. You don't want to touch the sheet that's going to go right up next to the patient's face with soiled gloves. You don't want to touch the curtain with soiled gloves. So once your gloves have touched the patient, try to pay attention of what else you're touching in the environment so we're not like the sandwich people just touching everything with those gloves. Good? Anybody ever watch medical dramas on TV and stuff? Oh, makes me crazy. Because on medical dramas, they'll put on a set of gloves and then they'll do like a bazillion things with those gloves. And when you understand this and you're watching, you're like, you touch that, you touch that, you touch that. And then you put your hands in the patient's mouth and then you touch that and you touch that. And you just kind of see how these pathogens get spread over the environment. Good? All right. And then we have to know how to remove our gloves properly. So that's what we're going to learn now is how to remove our gloves. What are we at? 11:50. Okay, so we're going to take a quick break because I'm a little behind. Let's go ahead and take our break. And when we get back, I'm going to talk to you about why gloves aren't the magic suit of armor you think they are and how to remove them correctly. So go ahead and take your break. So that's Julie. Julie is the one that teaches CPR. This is her classroom. So thank her for the snacks. But on the first day, you guys all got this paper. Whoops. I forgot to go over this with you. You guys all got this paper on the first day, right? Down here are some QR codes. This one on the very end is for Julie's CPR class, and she includes first aid and I think bloodborne pathogens. So you get all the certifications that you need at a discount, but you have to use this QR code to get the discount because it's a special registration. Okay. So you don't need CPR for the class. You don't need it for the test. You will need it to work. So this is a great place to get it. Plus you're in here in this classroom. Thank you.
So you're going to decorate the bathroom all cozy and cute. It's very
You like
cute.
it?
Yes, I love it.
Anything you need, you guys let me know. I hope to see you.
Thank you very much for the
I'll see you
snacks.
Thanks, Julie.
Thanks for the snacks too.
All right. Actually, let
Like
me.
everything I'm touching now. It's
Yeah.
crazy after that
Is
class.
this one? What size is this one? This one. Okay. So we're going to talk about, we're going to keep talking about gloves here real quick. But before I teach you how to take them off properly so that you don't cross-contaminate, we have to talk about what gloves actually are and what they're not. A lot of people tend to think that gloves are this magic suit of armor that's going to protect you from everything and life is grand, and it doesn't work that way. So to understand that, we got to talk about balloons. So if you've ever had a balloon like this, a birthday balloon, party balloon, you took it and had it inflated with helium, it stretched out, got really big. But what happens to that balloon over a couple days? Yeah, it deflates. And eventually you end up with this little sad little puff thing, right? So how does that happen? Well, latex, what these balloons are made out of, is the same thing that your gloves are made out of. And when you inflate that balloon, it stretches. It's fabric. It stretches. And all man-made materials have holes. Like if you took your t-shirt and held it up to the light, you'll see little teeny tiny itty bitty holes in it where the weave goes together. If you stretch that fabric, the holes would get bigger. Same thing with this. When you stretch the fabric, the holes get bigger. Now, these are microscopic holes. You can't actually see them with the naked eye, but they are there. And as you stretch that material, the holes get bigger, and that helium over time is actually able to wiggle out through those holes. Now, that tells us two things. Number one, the material has holes. And number two, when you stretch those holes, things get through. Good? Make sense? So when you put gloves on, you're going to stretch that material. And those holes are going to get bigger. And the holes, I mean, they're microscopic. You can't actually see them, but viruses are teeny tiny little things. You can't see those either. If helium is able to get through that hole, and we know it does because the balloons deflate, then pathogens can also get through those holes. So when you're wearing gloves, it is not blocking out all of the pathogens that you are encountering. Some of them will get through. And they've done a million studies on this, guys. This is probably one of the most common microbiology projects that is done. You wash your hands, you culture your hands, you put gloves on, you do something like handle raw chicken or something like that. And then you take your gloves off and culture the hands again. And in a perfect world, there won't be anything on them because you washed your hands and put gloves on, right? Every time, pathogens grow. Pathogens get through your gloves onto your hands. So those gloves do not do what you think those gloves are doing. They block out the majority, but they do not block out all. Now, in healthcare, we have this annoying mindset that if I wear gloves, they kept my hands clean and I don't have to wash my hands after I take them off. And you'll see this over and over and over again. But here's the problem. What does gloves make your skin do? What sweat? So on Monday, I told you guys to read Warm, Dark, Moist lesson in your book. Pathogens, all the bad guys, need 3 things in an environment to thrive. It needs to be warm, dark, and moist. Underneath the gloves, you've got a hand that is body heat hot, 98.6 degrees. That's warm. It is dark because gloves, for the most part, block out a lot of light. And when sweat gets through, we now have moist. So those pathogens that made it through the gloves onto the surface of your hands are now in the ideal breeding environment. And pathogens don't need boy pathogens and girl pathogens and dates and, you know, all that kind of stuff to make baby pathogens. It doesn't work that way. Pathogens need the right conditions. They zip themselves in half, and now we have 2. Ooh, that's bad. So when we are wearing gloves, we have to understand, number 1, it's not going to keep everything out. Number 2, the way the gloves fit are going to matter. If they're way too small and they really have to stretch, they're going to provide more opportunity for pathogen transfer. And number 3, you have to wash your hands after you take the gloves off. Good? Makes sense? Anybody ever see somebody wear gloves, take them off, and not wash their hands afterwards? Or use hand sanitizer? Yeah. Anybody ever wear gloves to, like, clean your toilet? If you're not washing your hands afterwards, it's wearing gloves didn't do you a thing. Did not do you any good at all. Because those toilet germs are now on your hands, and you're spreading them all over your house. Pretty gross. This is one of those situations, guys, where a little bit of knowledge can actually make it more dangerous for you. Because people wear gloves without complete knowledge. They think that those gloves are keeping them safe, and then they don't take the steps necessary that would actually keep them safe. If you didn't wear gloves and you cleaned your toilet, you would wash your hands. Make sense? Good. All right. So pathogens got through your gloves. We're going to make sure that we wash our hands after we take the gloves off. But let's talk about how to take those gloves off so we don't grossly contaminate. So all of you guys have gloves on your desk in front of you. So go ahead and grab a set of gloves and put them on. Here, do you need extra large? I took your extra, sorry. Yeah. All right, so when we're working with gloves, and I have notes for you on page 43, tells you how to remove gloves. But when we're working with gloves, there's some very defined steps that we have to take. Dirty glove can touch dirty glove all day long. This is not a problem. Dirty glove cannot touch skin. So I've got to take these gloves off without cross-contamination, but I'm going to cross over between gloved and ungloved in the middle, so it can get a little confusing. So when we're taking gloves off, you cannot go under. So glove cannot touch skin. You can't go under. What we're going to do is pinch up at the base here. Don't let your thumb go under. Just pinch up and pull that off inside out. When you do that, you want to wind it up in the palm of this hand so it doesn't, you know, spread germs everywhere. It doesn't wiggle around. You want control over it. Now, skin can touch skin, cannot touch dirty glove. So I'm going to go underneath this time, but a lot of people do it this way. If I do it this way, my thumb is probably going to touch this glove. So you want to have your palm against the skin. So you want to go underneath this way and pull that one off inside out. So I've got one inside out glove in the inside, the other inside out glove. Good. And then we're going to throw that away. You can take it home and clean your toilet. All right. So these are the 4 steps for the test. If you have a skill that you wear gloves for, remember, we don't wear gloves for every skill. It's only if we're going to touch body fluids, personal skin, or non-intact skin. If you have a skill that you are wearing gloves for, you are graded on how you're taking them off. If you decide to wear gloves for any skill, whether it's required or not, you are graded on how you take your gloves off. So yes, you can wear gloves during the test for skills that don't require them. You can. But the nurse that is grading you will probably tell you, you don't need gloves for that skill. You don't need gloves for that skill. Now, why would they do that? Cost. Those gloves are not free. Those gloves cost wholesale about $10 a box. Over time, that gets expensive. If you are performing skills all day long on multiple patients and you're wearing gloves for every single one of those, whether you need them or not, you're costing that facility money. What do you think is going to happen to your raise? Yeah, there may not be a raise, or it may be very, very small because all the money is going to supplies. So this works in the testing setting too. The test has to pay for the supplies that you're using. So if you're just grabbing gloves like they're free, the evaluator may remind you those aren't free. Make sense? Okay. All right. So these are the 4 steps. You pinch up at the cuff and pull off inside out. Make sure you're balling it up in the other hand, the glove of the other hand. And then we're going to go underneath and pull that one off. So here's the principles for this particular skill. We're going to use gloves if we might touch body fluids, personal skin, or non-intact skin. If we wear gloves, the first thing they touch should be the patient. We're going to remove them correctly, and we're going to watch for what we're contaminating in the environment with those dirty gloves. Flashcards are available. All right, so now that we understand those principles, remember, we have to know all of these principles in order to do this skill. Well, we know to follow the care plan. We know how to do our opening. Now we know glove rules, and we know the closing. So let's focus on the steps that are specific to this particular skill. At the top of page 53, we have our care plan. Our care plan tells us patient will be lying in bed for skill. Take the patient's radial pulse measured at the wrist for 1 full minute and record your readings. A bigger version of the care plan. So let's talk about what a pulse is. On the left side of your chest, you've got a heart. That heart contracts. When that heart contracts, it's like squeezing a sponge. Liquid's going to come out. Heart contracts and it produces a wave of blood. That wave of blood pushes the one in front of it, that one pushes the one in front of it, and that one pushes the one in front of it. If we count these waves, remember each one is made by a contraction of the heart. If we count the waves, we know how many times the heart contracted. That's what a pulse is. It's an indirect measurement of heart rate. Indirect, meaning we're not measuring the heart itself, we're measuring the amount of waves that heart produced. Indirect measurement of the heart rate. Now, what this is going to tell us is how quickly the heart was beating or how slowly. But it can also give us some other information. We want to pay attention while we're counting to whether the pulse is really strong or really weak. Is it regular or is it irregular? So what I mean by that is regular means that we can pretty much anticipate the next beat because it comes at a regular rhythm, right? Irregular would be more like this. You can't anticipate the next beat. Okay, so regular, rhythmical. Irregular, you can't really anticipate the next one. It's like all over the place. And you will have both. There are a lot of elderly patients that have AFib or atrial fibrillation that produces this really irregular heart rate. Sometimes they're a little bit harder to count because they're not rhythmical. Do the best you can. Good? Questions? So we're paying attention to how much the heart beat, right? How many beats there were. But we also want to pay attention to whether it was regular and whether it was strong or weak. Everybody has a different baseline. Some people's pulse is really, really strong. Others are really, really weak. And that could be their normal. We just want to relay to the nurse everything that we know. So when the heart squeezes, it pushes out a wave of blood. That one pushes the one in front of it. And when we measure this over a minute, so a full minute, so that second hand ends where it started, a full minute, that gives us our pulse rate. But we don't always have to count for that full minute. This care plan says we do. And we're going to get to that in a minute, but we don't always count for one full minute. So what am I actually measuring here? So the best way to understand this is to think of a garden hose. If you've got a hose attached to a faucet on the outside of your house, and I go over and I grab that faucet and I turn it all the way on, water comes through the hose. There's a lot of pressure. The hose expands because there's pressure inside that hose. If I turn the hose off, that water slows down to a trickle. The hose gets squishier because there's less pressure inside, right? So what I'm doing, can you say I'm putting on my gloves instead? No, if you need to wear gloves, if it's a skill where you're going to be exposed to personal skin, body fluids, or non-intact skin, and you need to wear gloves, you've got to put them on for the test. If you are working with a skill that doesn't require gloves or with a patient that doesn't require gloves for that skill, there's no need to even say it, okay? All right, so when the faucet is on, water is coming through, the faucet has more pressure. When the faucet is off, less pressure, less water coming through, right? So this is what the heart is doing. It's standing at the faucet, turning it on and off, on and off, on and off. So we're going to have more pressure, less pressure, more pressure, less pressure, more pressure, less pressure. And that's what we're feeling under our fingers. And even slasher movies get this right, guys. Anybody ever watch slasher movies? Right? So slasher movies get this right because it'll spurt. That's right. The blood spurts out. So a spurt is a wave. And when it stops spurting, it's the valley, right? So it spurts, 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 like that. All right. So how do we take a pulse? Well, we're going to use two fingers. Don't use your thumb. Your thumb has its own artery. You'll get your own pulse. It won't help you a bit. I don't need your pulse. I need the patient's pulse, please. So we use two fingers. And we're going to press down on that artery. And we want to press down enough that we can feel these waves moving under our fingers. If you press down too much, it's like a straw. You'll crimp it, nothing gets through. So if you push too hard, you're not going to feel anything. But if you don't push hard enough, if it's just a little bit, you're not going to feel anything either because the wave is down here, not up here where your fingers are. So this takes a little bit of finesse. We start light. We don't feel anything. We press a little harder. We wait. We don't feel anything. We press a little harder. We wait. We don't feel anything. Press a little harder. Ah, there it is. Okay, good. Makes sense? Okay. Remember, if you press too hard, you'll wipe it out. You won't feel anything. If you press not hard enough, you're not going to feel anything. It's kind of like the Goldilocks zone. And everybody's a little different. All right, so when we're doing this, we want to put our finger on the artery. We're going to press down, see how I'm down far enough that I can feel the waves. And we're just going to count the waves as they move through under our fingers. We want to count for how long? 1 full minute, because that's what our care plan said. So I'm going to put my fingers there. I felt the first wave. That's 1, 2, 3, 4. As they move through, I'm just going to count until the second hand goes right back to the starting point, and that's the reading. Normal is between 60 and 100. If we get under 60, what do? Yeah, tell the nurse. If we get over 100, tell it to the nurse. Sure, absolutely. When you're doing this, the patient's elbow needs to be supported. Now, remember, our information sheet told us our patient's going to be laying in bed for this skill. So you want that elbow on the bed, not held up like this. When you hold an arm up like this, takes effort. Couple seconds, it doesn't feel like it takes any effort. Hold your arm up like this for 2 minutes, and you'll be begging me to put it back down. It takes effort. That means those muscles have to contract. Contracting muscles need more blood flow. What do you think we're going to do to a pulse rate? Yeah, we're going to elevate it. Are we going to get an accurate reading? No. So the elbow has to be supported. If you're sitting down, on the table is fine. On the back of a chair, on something like this, on the bed, keep the elbow on the bed. Make sure it's supported, but don't do this. Good? Questions? All right. We're going to use 2 fingers, and you want to use the tips of your fingers, not the flat part. The tips, you have more nerve sensitivity on the tips of your fingers than you do the flat part. It's going to be easier to count those waves. Good. So where is the pulse? Well, let me go to the next slide here. So the pulse is going to be located at the very top of the thumb side of the wrist. So this is the thumb. This is where the thumb and the wrist join. This is the bendy part of the wrist where the lines are. So if you look at your wrist, you've actually got lines there. The bendy part, that's where you want to be, is on those lines or just barely below it. But one of your fingers should be on a line. If your fingers are not touching a line, you're too far down. Way up here. Good. Lines count. Color in the lines. All right, so we're going to use our fingertips, not the flat part of our fingers, just the fingertips. And one of the most important steps that everybody misses is that your thumb has to be on the back of the wrist. So what ends up happening here, thumb has to be on the back. What ends up happening is when you're trying to find a pulse, let's say that I want to find my pulse, and I put my fingers there, I might feel my pulse. I can feel the thump under my finger. I know where my pulse is. But we have to count for how long? Your fingers are going to relax. You can't help it. It's an autonomic function. Your fingers will relax. And when your fingers relax, you're going to lose the count because you're not pressing as hard. When you put your thumb on the back side in that C shape, that holds consistent pressure and you don't lose your count. Remember I said that this is the most failed skill on the test? This is one of the reasons that it is the most failed skill. The first is that people don't follow the care plan and count for 1 full minute. But the second reason that people fail is because they don't put their thumb on the back and they lose the count and they have to keep starting over and over and over and over. And when you do that, you run out of time. Make sense? So this thumb on the back is actually one of the most important steps because if you don't do that, you're going to lose the count. All right. So our care plan is very specific. It says 1 full minute. That's how long we're going to count because we know that we have to follow the care plan. Now, I know you guys are all rolling your eyes. It's only day 2. Just wait. You're going to hear that about 300 more times, okay, the care plan. But interestingly enough, I'm one of the very few instructors that teaches you to follow the care plan. Most instructors out there aren't even talking about the care plan. And I'm going to prove it to you. How many of you guys have your yellow book with you? Okay, open your yellow book. Go ahead and pull it out to the index, the very back of the book, the very, very, very back of the book. and look up care plan in the index. Look up, it is there, but look up care plan. What page is that on? Okay, so let's go to page 7 and 8. Now, we would expect a whole chapter here, right? As much as I'm talking about the care plan, right? One paragraph. In this entire book, care plan is one paragraph. So to you, care plan is like, oh my gosh, quit talking about the care plan. We got it. Thanks. Enough. But I need you to understand that that is not the norm out there. I don't know why. I wish I did. But I've got to take the time that I have with you to reinforce how important this care plan is, because otherwise, when you get out there, you're going to start making decisions that are not in the patient's best interest. Good? Because all of your coworkers have no idea what the care plan is for. They just don't. They weren't taught. That's scary. So that means that there's a lot of CNAs out there, and you're going to be working right alongside all of them, who have no idea how to care for these patients, and they're making it up as they go along. That's just the sad reality. If something goes wrong, they're on the chopping block, guys. I don't want you to be that CNA. I'm trying to protect your long-term career. Good? Okay. All right. Let me give you an example of why this is so important. This week has just been, it's giving me a headache. So in the medical community, there's a really big outcry, outrage situation going on with nurses in a specific state. And I'm not going to get into the state because I don't want to get a lot of hate mail. But there is a state out there. You'd be surprised at some of the comments I get. There is a state out there that if you do something wrong. So let's talk about these CNAs, right? That don't understand the care plan. They don't know what they're doing. They start making their own decisions. They're walking patients with walkers or without anything because they don't know what the care plan says. And something happens and they get charged with patient endangerment or neglect or something like that, right? And they have to go before the state board and they have to apologize for what they did and go through remediation, and they're able to keep their certification or whatever. But there's a flag on their profile. There's a flag there. Now, this person goes on for nursing. They go to school, they get their nursing license. That flag doesn't ever go away. So they go on for their bachelor's degree. That flag doesn't go away. They go on to get their nurse practitioner. That flag doesn't ever go away. And there's no way to erase it. So the mistakes that you make very early on in your career in this one particular state will haunt you for the rest of your career and could keep you from getting a position. Now, that's not the way it is in Florida, thankfully. We do have methods that we can use to remove, something from our record if it was a true mistake and we made amends and there's a lot of things that have to happen, but there is an appeals process. But not every state does. So the reason that I teach you the way I do, the reason that I say the same things over and over is because I don't know if you got it the first time or the second. I don't know if you understand how important this particular thing is, because it's not just today that I have to protect from you or with you. It's your practice 10 years from now. I don't want a mistake that you make early in your career to haunt you for the rest of your career. So I want to make sure that you're trained correctly from the beginning. I'm trying to protect the person that you're going to be later. Good? Does that make sense? When I realized that with this book, that it's only mentioned once, I went to the other 2 textbooks that are used. There's only 3 that are used for CNAs. I went to those. They're not there either. So if the instructors are using the textbooks and they don't understand the importance of the care plan, how can they pass it on to the students? Okay. Protect your ability to go on. Helen, hey, Helen. Good morning, Miss Patty. I wanted to ask whether you are still doing the question and answer shows on Thursday. No, unfortunately, Helen, I'm not. I'm in the middle of some really, really, really big projects that are taking up all of my time. So I used to do a weekly show on Thursdays, and that's what Helen is asking, where it was a question and answer show. So I would get on, I would give a little lesson about something like Hoyer lifts or communication, or should you go straight to our RN or should you do LPN first? We would answer questions like that. And I would do question and answers as well. So I would give a 15-minute lesson and then take questions from the group. And I loved it. It was a lot of fun to do, but it takes me like 2 days to prepare for that, to put the lesson together because I have to make slides and all of that. So I'm creating some new programs. So I don't, unfortunately, not doing that right now, but I do still do the practice test game show on the 1st and 3rd Tuesday of every month. All right. Colleen. Ms. Patty, just for clarity, if you have to supplies like bedpan, would you put your gloves on after you've collected those items? Anything used for toileting, you have to put your gloves on first before you touch it. Anything else, you should not have gloves on because the first thing your gloves should touch is the patient. So I hope that helps. But we're going to get into that in a little more detail with each of those skills. All right, so this care plan said 1 full minute. We understand how important the care plan is, but not all care plans are going to say 1 full minute. In fact, it's very rare. Very rare. If your patient's pulse is irregular, remember we talked about irregular? If your patient's pulse is irregular, you have to count for 1 full minute because you can't anticipate the next one. There's nothing regular about it. So irregular is always counted for 1 full minute. But regular, if it's just a regular old pulse and we know when the next one's coming and it's pretty, pretty routine, then we don't count for 1 full minute. We count for 15 seconds. And on a clock, if you looked at this clock, this is 15 seconds. There's 4 15-second segments in that minute. So if we just count for this 15 seconds and multiply that by 4, we get that full minute reading. So if your care plan says 1 full minute, you're going to count for 1 full minute. If your patient's pulse is irregular, you're going to count for 1 full minute. If the care plan doesn't specify, you can do this. 15 seconds, multiply by 4, and get your pulse rate. Most places now are using pulse oxes, which is a little clothespin looking thing. You clip on to the end of the finger, and it actually gives you the pulse rate. It'll say 80 or 68 or 72 or 112 or whatever it says is the pulse rate. You don't have to multiply. You don't have to do it. You just look at the number. That's the pulse rate. That's for blood pressure, but blood pressure monitors usually give you your pulse rate as well. Okay. We're going to document this. They're going to give you a documentation form. It looks similar to this. During the test, you're going to write the number in the box provided. In Florida, if you have 2 evaluators, there will probably be 2 spaces to document because you're going to have to count with each one. Okay, good. Questions?
Is it like blood pressure with specific risk, one's better than the other? Or does it matter?
No, because for pulse specifically, I'm not going to talk about blood pressure will be next on Monday. But for pulse specifically, the pulse is the wave of blood. So we're counting how many waves of blood. The heart is what makes the wave of blood. So when the heart squeezes, it pushes that wave out, and that wave goes everywhere in the body. So it doesn't matter whether we're over here or any other pulse point that we're using. It's all the same heartbeat that we're counting. Blood pressure is a little different because that's going to be based on the size of the blood vessel compression. Bigger hose, less pressure inside. Smaller hose, more pressure inside. So it depends on the size of the blood vessel. That's why left is usually best because it's a
That's why I
bigger
prefer-
hose.
I prefer-
Yeah, bigger hose.
It says, like on one of the stats, report abnormal values to the nurse. During the test, if it's abnormal,
You don't have to report it.
okay. But like if it is abnormal, like do we just say I would report that to the nurse?
You don't have to. You can. You can certainly say, yeah, the pulse is 112. I would report that to the nurse, but it's not a graded checkpoint. And they can only grade you on what's on the checklist. They can't add anything to it. So you can if if you want. It's not uncommon, guys, by the way. During the test, it is not uncommon to get a high heart rate. Who's your patient for the test? Another testing student. And they're getting ready to test. So do you think they're nervous? What do you think nervous does to your heart rate? Elevates it. So it's not uncommon to have a high heart rate on the test because of the anxiety in the room.
Will it also be the same like in a hospital setting?
Sure, yeah, because patients are anxious. They don't know what's happening to them. White coat syndrome is real. So yeah, absolutely. And one of the things that I always do when I'm taking vital signs, it's all about your approach. I'm a very calming presence. I know that. And I've worked very hard. I wasn't when I was young. I was that, hyper person. I would just in fact, my nickname in high school was hype, right? I know. But over my nursing career, I had to learn that did not do my patients any favors. And I had to learn how to create this calming demeanor. So when I'm working with patients, particularly patients that are undergoing a lot of stress, I will take the time while I'm talking to them before I get their vital signs to really try to get them at ease. And when I'm getting ready to take their pulse or their blood pressure, I'll tell them, okay, I'm going to take your pulse now. I want you to take a deep breath and think happy thoughts. And then I'll start taking the pulse. And the first couple of heartbeats, you can actually feel like thump, thump, thump. And then you'll actually feel them start to relax. But their reaction is going to be all about you. So when we're working, especially in a hospital setting where everything is just they're so keyed up because they're afraid. So I'll take that extra little bit of time just to kind of de-escalate. I lower my voice. I slow down my speech. I try to make everything pretty even and monotone. Do you see what a calming influence that has? So if you can work on that, you'll get much better vital signs from your patients. Good? Okay. All right. So this is our checklist for pulse. This is everything that we need to get checked off. There's a lot of checkpoints there. We're going to use these principles to check all of these steps off. So let's do that together to see how this works. Okay. Remember our care plan, right? Our skill rules tell us we're going to follow our care plan. Our care plan said radial pulse measured at the wrist. That means for the test, there's a checkpoint that says, did they take the radial pulse measured at the wrist? There are other pulse points in the body. We've got brachial, which is here. We're going to learn this one on Monday with blood pressure. You've got carotid, which is up here. And if you've ever been into a gym where you had like a personal trainer, they probably taught you how to take your pulse here to measure whether you're getting into a good pulse rate for fat burning or cardio, right? That's this carotid. You've got axillary, which is underneath the arms. Now, we usually only use that one in infants because it's a nice strong pulse. And they got baby fat. So baby fat here and here keeps us from really being able to feel those pulses well. So we use axillary for infants generally. We also have femoral, which is here in the groin area. And we use that if we think that there is a blood flow issue down below the trunk. You've got popliteal, which is in the very back of the knee. And then you've got a dorsal pedalis, which is at the top of the foot, like the arch of the foot. A lot of pulse points. And there's even more than that, but those are the main, what we call the main pulse points in the body. So there's a lot of pulse points. Now, this care plan is pretty specific. It says radial pulse measured at the wrist. If you use any other pulse point, you did not follow the care plan, and therefore you're probably not going to pass. Now, there's one more pulse that's not, it's a pulse, but it's kind of not a pulse. Okay. It's called an apical pulse. And an apical pulse is when you take a stethoscope and you listen to the heartbeat and count that. Now, it's not a pulse because remember, a pulse was a wave of blood. We're not measuring wave of bloods. We're actually listening to the heart. So it's called a pulse, but it's not measuring the same thing. What we're measuring is the heart's valves opening and closing, but that's not going to tell us how strong that pulse is. So if you're taking the apical pulse, you didn't follow the care plan. And this happens to a lot of students during the test because they think they're going to get fancy and extra credit. Because this is apical pulses are usually nursing things. So they put in your little stethoscope and they listen to the heart and they say, I got 72, and they write it down and they think that they did a great job and they fail the test and they don't know why. And I know that because they contact me and say, why did I fail? It's not about going above and beyond. It's not about getting extra credit. It's not about showing everything that you know. It's about following the care plan. Good?
So how do the finger clips actually measure the blood pulse?
So the pulse ox is going to use something very different. It actually uses light. And it's like an infrared. And when you put it on the finger, it can actually, through light, detect, it sees the waves. We're feeling the waves. It sees the waves with this ultra, I think it's infrared light that it uses. There's infrared and ultraviolet, and I get the two confused. I think it's infrared.
Do you often or have you seen differences in, taking somebody's and then those, like a lot?
No, it's actually, yeah, the pulse oxes are actually pretty consistent. They're usually, unless there is something else going on with the patient that can interfere with it, it's usually pretty accurate. What's not accurate are wrist blood pressure cuffs, which one of you guys asked me about before. Yeah, the wrist blood pressure cuffs, those aren't as accurate. All right, so our care plan told us radial pulse measured at the wrist, that's a checkpoint, and then count for 1 full minute. That's a checkpoint. As long as you're following that care plan, you're going to get those 2 checkpoints. Congratulations. Let's keep going. We have to record our readings. Our care plan told us to. As long as you're doing that, you're in good shape. We're going to knock because we need that checked off. We're going to greet the resident because we need that checked off way up there. We're going to address the patient by name. We're going to get that checked off right down here. We're going to introduce ourselves because we need to, up there, introduce self. We want that checked off. We're going to describe the skill. That's number 2, provide explanations to resident about care before beginning. We're going to get that checked off. We're going to obtain permission. It's part of preferences. We're going to close the curtain because that's a checkpoint. Starting to see everything I taught you is going to get checked off. If you don't do these steps, you're not getting the check marks. It's not about taking the pulse. It's the whole package. Good? Good? Okay, we're going to refrain from touching the resident before hands are clean. We talked about that as well. We're going to use standard precautions. So if I'm taking this person's pulse, do you see any wounds, rashes, sores, incisions, body fluids there? No, I don't have any on my hands. There's no open skin that's going to touch open skin. Do I need gloves? No. Do I need to wash my hands before I touch her? Do I need to wash my hands after I touch her? But do I need gloves? No. Good. Now, if she had an incision on that arm, do I need gloves? Yes, because there's an open body part, right? Open skin. So are you guys seeing it's not based on the skill, it's based on the patient we're doing the skill on.
Would you wash your hands before you record the results?
Yes, you wash your hands before you record and after.
Just curious, in the rooms themselves where you do these tests, are you actually doing the hand washing every time? Or
Yes.
just saying I'm doing it?
So yes and no. Okay, so your first skill, remember we get 3 skills on our skill sheet. The first skill, you're going to wash your hands during your opening, before you touch patient, and you're physically going to go wash your hands after. Okay, and then if you document, you'll wash your hands again. During skill 2 and 3, they're going to tell you can simulate hand washing. Simulate means say. So all you have to do is say, I would wash my hands now. You don't have to go to the sink. You don't have to rub them together. You don't have to do anything like you would just say, I would wash my hands now.
Real quick, are you being, during the test, are they recorded, video, audio, anything, nothing? No.
And then so for that first 5 minutes, it's just for the first hand washing then?
So 3 minutes is what they give you extra for hand washing. And hand washing, remember, we're rubbing for 20 seconds. So if we go to the sink, we turn the faucet on, we wet our hands, we get soap, we rub for 20 seconds, all surfaces, we rinse, we dry, we turn the faucet off. That whole thing should take about a minute.
And then that would just be for the first part of the hand washing.
Right.
And then the other 2 steps, you wouldn't have to wash your hands.
So, well, for the first skill, you're going to have to wash your hands.
3 times.
Yeah, probably twice. Yeah, twice usually. They usually don't have a documentation skill as the first skill. Okay. The order matters, guys. The order of these skills, you have to do them in order. Okay. But you're going to start simulating when your evaluator tells you to simulate. It's that simple. You're going to wait until they tell you. So let's say this is a good example. The first skill on this skill sheet is respirations. That's a documentation skill. So we need to wash our hands 3 times, once before, once after before we document, and once at the end. We're going to simulate when they tell us to. So we did our opening, washed our hands, counted respirations, washed our hands, documented, and then they're going to tell us you don't need to wash your hands anymore. So we're going to say, I would wash my hands at the end. So you're going to simulate when they tell you to. Where do those evaluators want to be? Yep. Home in their pool drinking their margaritas. They do not want to watch you wash your hands any more than you absolutely have to. Because let's think this through for a second. Remember where those evaluators want to be. Okay, keep that in the back of your mind. 1, 2, 3, 4, 5, 6, 7, 8. You 8 people are testing today. You go first. You've got 3 skills. So you're going to wash your hands before the first one and after the first one, before the second one and after the second one, before the third one and after the third one, and it's a documentation skill, so 1 more time. So how many hand washings is that? 7, and everybody gets a documentation skill. So you're talking about 7 hand washings per person. So 7 for you, 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 and 7 for you. And that's time that they could be spending in their pool. They aren't going to let you wash your hands any more than you absolutely have to, because they don't want to be there. So when they tell you to simulate, simulate. But here's a clue. If you get done with your first skill and they didn't tell you to simulate, don't simulate. They're grading your next hand washing, which means you went wrong somewhere on one of the other 2. So start paying attention to your hand washing, because something went wrong and they're low key giving you another chance without telling you. Okay, good.
Should they start to say, go ahead and simulate, is that going to change the allotted time given for the next 2 skills? Or
No.
You're still going to get 30 minutes or whatever time allotment is regardless of what you say.
Regardless. Regardless.
So you've actually bought yourself more time.
You did. You did. So your timing is based on the entire care plan set, all 3 skills. It's not, for the purposes of getting that full timing, we have an amount of time per skill, but that's just for computation purposes. So this skill, they give you 5 minutes to do for computation purposes, but you actually have, 35 minutes to do this whole skill set. So that's regardless of how many hand washings you're doing.
So you can essentially get yourself an extra 5 minutes because you're already.
Yes. Yep. All right. So we're going to use those standard precautions and figure out whether we need gloves for this particular patient. We're going to support the arm because our checkpoint tells us to. We're not going to use our thumb because our checkpoint tells us to. We're going to use our fingertips, not the flat areas. We know where to find the radial pulse, and we're going to count for that 1 full minute. Remember, you have to say start and stop so the evaluator knows when to start and stop, and you're going to document. We're going to leave the bed in the low position and make sure our environment is clean. It's a checkpoint. You're going to ask the resident about comfort. That's a checkpoint. You're going to make sure they're covered in bed, open the privacy curtain, and give them the call light. Those are checkpoints. And we're going to document. We also have a checkpoint that says end skill with clean hands. So if we're following the care plan, if we're doing our opening, evaluating if we need gloves, and doing our closing, look how many checkpoints we got. Yeah. Do you see how many are in black? 2. Out of that whole list, this is all that actually relates to taking the pulse. Do you guys see that? That's why I have to spend so much time teaching you the opening and the closing and glove rules and all the principles, because those aren't going to be on the care plan. You have to know to do those. But there's only that much that really has to do with pulse. And I'm going to give you a clue. Even if you get those wrong, you're still going to pass as long as you got all the rest of it right. And the cool thing is that we're going to do the opening in front of every single skill. We're going to do the closing at the end of every single skill. We're always going to follow the care plan. We're always going to figure out if we need gloves. Those don't change. We learn them once and we just do them over and over and over and over and over again. And every checklist looks like this.
Say we get the pulse skill that we're supposed to do, and we're in Florida, so we have 2 people there. In between your documentation,
Okay, yeah.
you have to wash again before you do the second one.
Okay. So remember, they're going to tell you when to simulate hand washing. Okay. This is one of those times that they are very strategic about this. Very strategic. They will tell you when to simulate. Just follow their lead. Just follow their lead. But yes, you do have to wash your hands before you document. And then again after. But whether you actually are physically washing or simulating will be up to the evaluator. Follow the rules. Follow the rules. But they'll tell you when you can shortcut. Good? Great question. Remember that this care plan is only for this patient. This care plan does not apply to this patient. This care plan does not apply to this patient. This one was written for this person only, period. Now, this person's care plan might say the same thing. That's coincidence. Every care plan is written specifically for that one patient. So in a clinical setting, you may not have any care plans that match. You might be taking a pulse differently on this patient and that one and that one and that one. There is no one size fits all because we're all human. We're different. We have different needs. Questions? Questions? All right, Jacob, I want you to put the pulse video on. While you're watching this video, we're going to practice pulse together in just a few minutes, okay? So just relax for a second. But I need you to see the whole thing, how the whole thing is done from beginning to end before we do it together. When you're watching this, on the bottom of the screen, you're going to see the actual checkpoints as I do each step. You'll see the checkpoint on the screen. But when I start counting, you're going to see the words get bigger and smaller as I'm counting. That is what I am feeling under my fingers. I'm showing you on the screen when it's big, that's a thump going through, a wave, we're going to count it. And when it gets smaller, that's the in between the thump. So if you count that, big, 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 big. If we count each one of those while you're watching the video, at the end, I'm going to document the number that I got, see how close you are. Remember, for the test, you could be off by 4 beats in either direction. But it's a way of making the video interactive where you can actually participate in the video. Otherwise, you're just watching me stand there. That's boring.
Ready?
I'm ready.
Hello,
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to take your pulse. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and I'll be right back. Okay, now that I've washed my hands, I'm going to elevate your forearm, keeping your elbow on the bed. I'm going to find the pulse, which is on the thumb side of the wrist. 2 fingers, thumb on the back. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? Pick a starting point on the clock. Ready, set, start. Stop. Thank you very much, Mr. Jones. Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. Here's your call light. If you need anything at all, just press that red button and we'll be happy to help you. I'm going to go ahead and open the curtain. The bed is in the low position. I'm going to go wash my hands. In Florida, you would count with the second evaluator at this point. For the purposes of this demonstration, I'm going to document and wash my hands. After washing my hands the final time, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right. Any questions? Okay. So we're going to do this together in just a moment, and I'm going to break you up into groups of 3. We'll have to pull Jake over. All right. You 3 are going to work together. Okay. I'm going to assign you roles. Please remember your role. Okay. You are the CNA. You are the patient. You are the evaluator. Okay. So I'm going to ask you to come over here, have a seat. Okay. And oops. Let me see here. Can I have you come sit right here? And you come sit right here. Okay. So you are the patient, you are the CNA, you are the evaluator. All right. You are the CNA, you are the evaluator. Jacob, we're going to need you. You're going to be right here. You are the patient.
All right.
Okay. So can you bring your chair over here? You're going to be on the end with your chair. You are the patient. You're the patient. You're the CNA, and you're the evaluator. All right. So we are going to take each other's pulse. We're going to do this 3 times. So everybody's going to have an opportunity to play each role. That means that you're going to be taking a pulse on 2 different people. So you can kind of see how the pulse can feel a little different. The patient, when I gave you a patient role, so everybody on the ends of the table is the patient. You're going to put both of your arms out supported on the table. The other 2 people, you're going to find the pulse on the arm closest to you. Now, there's 2 ways that you can do this. You can do an overhand grip or an underhand grip, but your fingertips need to be at the top of the wrist, like this, and your thumb on the back. So you can go like this, or you can go like this. See how you can go over or under? You can also do like a guitar hold as well. So it doesn't matter how you find the pulse, just get into a comfortable position for you. But you want to use your dominant hand. So if you're right-handed, use your right hand to find the pulse. So I'm going to come around. Ow. Yep, you got it? Okay. So where the pulse is, so let me show you guys. If I put my hand out with my thumb facing up, like I'm going to shake somebody's hand, right here where the thumb and the wrist meet at the bendy part, I'm going to put my fingers at the top, there's a bone there, and roll forward and put my thumb on the back because the artery that we're trying to find is right underneath that bone. So you should be way up here at the very top. If you're in the middle, you're not in the right place. Way up here at the very top. So find the pulse on the hand that's closest to you. When you have the pulse, I want you to say yes. When you find the pulse, say yes. Do you have the pulse? If you need help, let me know. If you need help, let me know. Got it? Okay. So it's right here. Not quite so hard. A little lighter. Got it? Okay. I'm going to do the timing for you. I am going to say start. When I say start, you're going to count the thumps you feel under your finger. When I say stop, you're going to stop counting the thumps. Everybody ready? Set. Start. Stop. What'd you get? What'd you get? Okay. What'd you get?
55.
58.
Okay.
He said 94.
I'll show, no, I'll show you. I'm normally low.
All right. When you were the patient, how long was that minute?
Forever.
Oh my gosh, it was forever. We're not used to, as patients, we're not used to people sitting there for an entire minute saying nothing. This is going to ramp up their anxiety. They're probably going to start talking to you. And that'll derail you. So when you have to take a full minute count, I need you to understand this is a long time for your patient. So you want to kind of warn them, hey, this is going to take me a full minute. I'll need you to remain quiet, but I'll let you know as soon as I'm done. When you do that, they relax. They know it's supposed to take a full minute. They're okay with it because it's expected. It's that fear of the unknown in medical that gets your patients. Make sense?
Okay to talk that out when you're doing your testing? What you just.
Yeah, I that's how I do every pulse. It's going to take me a full minute. If I'm doing a full minute pulse, it's going to take me a full minute. I'll let you know when I'm done, but I will need to remain quiet until then. When you say that, and it's nice, it's just a nice way of saying it. I'm not going to say shut up, right? You want to be nice about it. But when you do that, that your patient just relaxes. If they know it's going to take a minute, they're okay with it. But they may ask, well, why are you doing this for a minute? Just say, the nurse told me to. You guys have a get out of jail free card here. All you have to say to anything is the nurse told me to. Take it up with the nurse. You don't have to answer those questions, right? That's why nurses go to school for 3 years to learn how to answer those questions. Not on you. All right. So now the person who was the patient is now the CNA. So the person that was the CNA is now the patient. So patients, put your arms out. You guys remember your roles? Probably not. So, okay.
Still a patient, right?
You are now the patient. 2 arms out. You are now the patient. 2 arms out. So you're going to take her pulse.
Okay.
I don't know.
You're the evaluator. No, you can stay in your seats.
I just figured it would be easier.
You're still the evaluator. Still the evaluator. So patient, put both arms out.
Just feels very odd. And then just trying to keep your hand there.
Patient, put both arms out. Now you guys find the pulse on the hand closest to you. So you're going to find the pulse on that hand. You're going to find, yeah. Find the pulse on the hand closest to you. When you have the pulse, say yes. Everybody good? No. Who's no? Okay. Let me help. Okay, it's right here. I don't think you're pressing hard enough. It's right here. And you kind of want to push it a little bit, just a little bit toward him.
I can't push it that
No,
way.
no, no. Your fingers, not her, your fingers.
Oh.
There you go. Not that hard. Little loose, little looser. You feel it?
Wait.
Push a little harder then.
Okay.
Good?
Yeah.
Okay.
Yeah.
All right. Ready? Set. Start. Stop. What'd you guys get? Guys?
68. She got 71, I got
Okay.
62.
Okay. Are you guys all somewhere within 4 of everybody else's? Okay. Last person is now the patient. Put your arms out.
It does feel very odd.
Other than that,
The more you think about it, the more likely you are. Yeah. The best thing you can do when you get a pulse taken is just focus on breathing. Just relax, clear your mind.
Okay. When you have the pulse, please say yes.
Yeah.
Everybody good? No? Okay. All right. So with her, hold on. I can see the problem. I would like you to relax your arms onto the tables.
okay.
Relax your arms. The reason is she's got a lot of tendons in there. And when it's up like this and she's flexing, you're covering up that artery. So
from underneath your elbow.
no, you're okay. You want her wrists relaxed.
Yeah, if the wrist is like hyperextended,
We want-
it's going to make it harder to find that.
Yeah, we need kind of limp wrists. You can't find it? Okay. So again, I want you to relax for me. Just relax.
I feel it.
It's right here. Right here. Yeah. Oh, you got it? Oh, okay. I'm sorry.
It was.
Use your fingertips. Use your fingertips. Okay. Oh, so it's you. Okay. Let me see if I can find it. Yeah, it's right here. Hers is very faint. Oh, your hands are very cold
I
too.
know, I'm freaking her out probably.
So it's right here. You got to press pretty hard. Hers is faint. All right, guys, you ready? Everybody good? Set. Start. Stop. How'd you guys do?
I lost it halfway through and it came back.
Yeah, I feel like you
Okay.
were coming in and out. I don't know if it was the pressure or what, but it felt a little bit harder to get.
I was, yeah, it was,
I don't know. When I was flexing my hands,
yeah, because it was going good, then all of a sudden.
I just wanted to open my hands. Yeah, that's the other thing too. It's like you want to move.
Okay. Resume your normal seats.
I was somewhere, I lost it somewhere, I guess. In the 50s, I guess.
I got 79, so big.
All right. Do you guys have a vague idea of how to do pulse?
I won't fail it now.
Okay. Whoops. Oh, I'm going to fall. All right. You guys should be able to go home and practice this on the unsuspecting public at home. You can also practice this one on yourself. This is one of the few skills you actually can do on yourself. Find your pulse, look at the clock, pick a starting point, and count. Couple things with this really quick. Go ahead.
So like, I mean like, how like weird and silly am I gonna feel like when I'm looking like I should know what I'm doing and I can't find the person?
That's where practice comes in.
That's not gonna happen because I'll be practicing.
Right. That's where practice is going to come in. Now, that's what I was about to say. A couple of things with that. Okay. Do you guys remember on Monday, I talked to you guys about the test, and I said after that they check you in, they're going to go away for a little bit and they're working on putting you guys together, right? You guys remember that? All right. One of the things that they're considering is anybody that has pulse as a skill we want to partner you up with somebody that is going to have a decent pulse. This is entry level skills competence. You are not proving that you are a master CNA. That's not what this is. This is entry level. So that means that we have to find the easiest possible patient for you. That's why if you're going to transfer somebody, it needs to be your body size or smaller. Okay, entry level. So in general, for pulse, we're going to look for people that are younger or young middle age, people that aren't too thin or too large. We're looking for middle of the road as a patient for pulse, because as we advance in age, our blood flow often gets compromised because our arteries fill up with plaque. So with older individuals, a lot of times the pulse rate is going to feel very faint. Make sense? Okay. We don't want that patient as a patient for testing. We want somebody who's got pretty good blood flow, that's easy to find, easy to feel. Now, super tiny people like you, okay, super tiny people, you got a whole nother problem going on. And that's, some of you probably actually felt this, where the pulse rate sped up and then slowed down and sped up and then slowed down. This happens in super tiny people and in older people and in the very young. And let me explain why. It's all about space, real estate. In here, I have a heart and I have two lungs, and they both are moving all the time. They are covered in a cage. We call it a rib cage. And in my back, I've got my spine, and my front, I got my sternum. So you've got these three organs, your two lungs and your heart, that are constantly moving, and there's bone that's keeping them from moving too far. Good? Make sense? All right. So in super teeny tiny people, there's not a whole lot of space there. This is like your tiny 200 square foot apartment in Manhattan, right? Not much space. So when the lungs inflate, they get bigger. That puts pressure on the heart, and the heart goes, whoa, and speeds up. As you exhale, the heart has more room, and it goes, ah, and the heart rate goes down. Make sense? So we'll see that a lot with the pulse. It'll get real, it'll go up, get fast, and then it goes a little slower, and then it goes up, and then it goes a little slower. And that's totally normal. And it all just has to do with space. That's not irregular. That's kind of a regular irregular. Okay. It's kind of expected. But I probably wouldn't use you for pulse. I'm definitely not using you for pulse, because really, really cold hands like that tells me that your circulation to your hands might be impaired, which makes your pulse maybe a little bit harder to feel. I would not, guys, nurses assess like we breathe. I know more about each one of you than you think I know about you, just because I'm a nurse. Nurses assess like we breathe. So when you're being checked in, those evaluators are gathering all kinds of information about you, and that they need that information to pair you up with somebody else. Okay. Does that answer your question? Okay.
So you lose the pulse for a couple of seconds. Do you just
stop?
Or do you restart?
Yep. Just stop and say, oops, I lost the pulse. I'm going to restart. But who do you think you should be talking to? The patient. That's right. Those evaluators don't count. They're smart cookies. They'll keep up. They'll start counting when you do. But you want to talk to the patient, because they're the ones that really matter. So I would just tell the patient, oh, man, my brain wandered. I think I need lunch. I got to start over. Just normalize it. It's okay. It's all right. I use a lot of humor. Humor is a great equalizer, guys. Good? Questions? You got a pretty good chance of getting this one on the state exam. Remember, there's 4 documentation skills. There's pulse, respirations, feeding, and drainage bag. Pulse, it shows up, I think, on 3 different care plan sets. So you got a pretty good chance of getting this one. Respiration shows up more. Respirations, you've got a really good chance of getting, and we'll get to that next week. So do you guys understand a little bit about pulse, what it is, why we take it, and what we need to report? For the exam, you're only counting rate. They're not going to ask you whether it was regular or irregular. You're not going to have to say whether it was strong or weak. You don't have to. It's just rate that you're being graded on. But I want you to be aware of the others, because if it just feels funny, if it's not right, you need to know to report it. Good? All right. Whew, man, I am so late. All right, let's go to 102. I'm going to get through this quickly. This is dressing a resident with a weak arm. If you look down the side, you're going to see a whole lot of principles, and some of them we don't know yet. They're all spelled out for you at the bottom of the page. We've got some test-specific information. They're going to give somebody like you 14 minutes to do this skill. You're getting them dressed. 14 minutes. Yeah, you're just getting them dressed. And you're only putting pants, socks, and shirt on. That's it. And they're a mannequin, so they're not uncooperative, right? You're not chasing them around the house. If you look at the top of page 103, you will see our care plan and step-by-step instructions. Supplies are along the bottom. Here's your care plan. It says, dress the resident in a long sleeve button or snap front shirt, pants, and socks. Resident is lying in bed, has a weak right arm. You might want to underline that or highlight it or something, because that's going to affect how we dress this patient. During the test, you want to pay attention to your care plan and find out which arm is weak. Very important. If no arms are weak, you're just going to get them dressed. That's easy peasy. No special accommodations needed. But if they have a weak arm, and they will for the test, they will have one arm that's weak, that affects how we dress them, because we don't want that weak arm to have to move any more than it absolutely has to. So if your patient has a weak arm, let's say they had a rotator cuff surgery, or they had a stroke and one side is affected. They have an arm that doesn't work real well. We tell the families, go get us button or snap front shirts. We want to dress them side to side, bless you, not top to bottom. We're used to pullovers. The shirts you're wearing, pullover. Mine, pullover, right? We're used to that. But if you've got a weak arm, you don't want to pull over. That means your arm has to move. Arm can't move right now. So we're going to dress them side to side. And when we do that, we're going to use a very specific method. It's called USA First. Undress strong arm first. When you do that, the clothing just slides right off that weak arm. And then we're going to dress the weak arm first, so the new clothing just slides right up that weak arm. We're going to make that stronger arm do all the work to finish us off. So we want to know which side is weak. If both sides are weak, they get a patient gown. Something that's opening in the back, we can just slide it on. No movement really required. Good? All right. We got 3 new principles to learn, though. These are quick and easy, however, not like gloves. Gloves took forever. These are very quick and easy. Let's start out. Remember, your principles are not on your care plan. They aren't going to tell you need a barrier. They aren't going to tell you need a privacy blanket. They're not going to tell you to use linen rules. The care plan doesn't say any of that. These are just things we need to know to be successful. So page 84 is going to go over barrier. If you look on the side there, you can see all of the skills that are going to use this particular principle. So there's a lot of skills that are going to use the barrier. Lucky for us, it's pretty easy. Notes are going to be on page 85, and I'm going to go through this pretty quick. Very quick. All right, these tables right here. When we get supplies, we have to have a place to put them. This table is not clean. It is used for meals, for chapstick, for dirty tissues, for all kinds of stuff. This table is not clean. I don't want to put clean supplies directly on this table. It'll contaminate them. So I need something in between. That something is called a barrier. Anything can be a barrier. A washcloth, a towel, a paper towel, a newspaper. Anything can be a barrier, something that separates a dirty surface from your clean supplies. But for the test, we're going to use a very specific kind of barrier. This This is called a disposable underpad. There are other types of underpads that we wash. We call those bed pads. So we have a disposable underpad and we have a washable underpad, but those are way too many syllables. We like shortcuts. So we call this one a chucks because it's the kind that you chuck after you use. So you will hear this called a chucks. The washable ones we just call bed pads. So chucks and bed pads. For the test, we're going to use a chucks as a barrier, and we're going to put it on the table with the absorbent side facing up and the waterproof side down. Good? Now we have a clean place to put our clean supplies. Remember, anything can be a barrier. Anything. For the test, we're going to use a chucks. Good? All right. So when we're going to use I'm going to get through this real quick here. When we're going to get supplies, we have to have clean hands to get our clean supplies. So we're going to do our whole opening, wash our hands, and then get our supplies. We're going to start with a barrier. It's first thing we get. A barrier and put it on the table. Don't get the rest of your supplies yet, because there's a principle here. You cannot let your supplies touch your uniform. Remember, your hands are clean, your supplies are clean, but your uniform is not. It has brushed up against that curtain. It's leaned against the sink. It's knelt on the floor. It's leaned against the bed. Your uniform is not clean once you start work. You don't want to hold stuff against your dirty uniform. It'll contaminate it. So we wash our hands. We go get a barrier. We put the barrier. I'm trying to get through this a little quicker here. We put the barrier on the table, and then we go get the rest of our supplies. Good? Questions? Takes 2 hands to unfold the barrier. If you got all your supplies, you're going to end up smushing them against your uniform to unfold the barrier. All right. All right, so get the barrier first, put it on the table, go get the rest of your supplies. Questions on barrier? Told you these are quick. Next one we're going to talk about is privacy blanket. So this is located, I don't have it on here. It's in your skills book. It's on page, what is it? 100. Privacy blanket also has another name. I don't know why. Healthcare, everything has 2 names. Don't know why. Privacy blanket is also called a bath blanket. Pick a name. Nobody cares. But a privacy blanket is going to be used anytime the patient is uncovered or undressed. I want you to think about the temperature difference perception between this patient and me. I'm fully clothed. I'm active. It feels warm in here to me. My patient is not fully clothed and they're laying down. They're not active at all. It's going to feel way colder in here to them. If I take that sheet away, it's going to feel freezing, but they're also going to feel exposed. So we use a privacy blanket if the patient isn't going to be covered by the sheet during the skill. We've got to give them a consolation prize. Don't just pull a sheet down and leave them there. I don't want to see knobby knees. Good? Make sense? All right. Yeah, I've been saying that for years. I don't want to see knobby knees. I actually ran into a former graduate who was working up at the local hospital. I ran into her at a store the other day. She's like, oh my gosh, Miss Patty. She hadn't seen me in like 10 years. She's a nurse now. She says, every time I uncover a patient, 10 years, every time I uncover the patient and I see their knees, I think of you. No knobby knees. She says, but I always make sure those knees are covered. It makes a difference in the way your patients perceive the care they're given. Makes a big difference. All right. So your privacy blankets are going to be used not just for privacy. I know we've got the curtain, but you're inside that area with the patient. You are a stranger. That curtain doesn't do anything to protect them from you. So you need the blanket as well as the curtain. Curtain is for everybody outside. The blanket is to protect them from you. Good? Questions? So we're going to use it every time the patient's uncovered or undressed, and we're going to put that blanket over the sheet. Don't snap it. Don't shake it. Just lay it down over the sheet and pull the sheet down underneath so they're never exposed during the skill. Okay? Don't snap or shake. Everything on that bed, skin cells, yeast, bacteria, you don't want to bring it right here where you can breathe it in. When you snap it, it creates a vortex, brings all that right up here, and you will breathe it in. And that's gross. Don't do that. All right, don't touch the sheet with soiled gloves. That sheet's going to go right up next to the patient's face. So if we use a privacy blanket, we take it off after we take our gloves off. That way, you're not touching the sheet with soiled gloves. We'll get into that a little bit later. All right, and then we have, let me just get through linen rules and then I'll let you go. You'll need to watch dressing video tonight or over the weekend because I'm not going to get to it. Linen rules. On page 87 are your notes. Linens can't touch your uniform. We already heard that. That's a repeat. You have to have clean hands to get your linens. We already know that. That's a repeat. And we don't snap or shake linens. We already know that. That's a repeat. Guys, things that I repeat are doubly important on the test. These are the checkpoints that are weighted heavily. If I repeat the principle, it counts big on the test. So don't let the linens touch your uniform. Make sure you have clean hands to get your linens and don't snap or shake them. One more thing on this. We're going to skip 2, come back to those later. But one more thing you need to know about linens is if you don't use it, it has to be discarded. You cannot save it for later. Anything that's out of our sight is not considered clean. I don't know if somebody mopped up coffee on the floor with that washcloth and put it back on the stack. If it's out of your sight, you can't consider it clean. So you use it or you lose it. Good? Questions? All right. So let me go to I don't know what's okay. Let me go back here. I'm not going to get there. Okay, so over the weekend, I can't find the right slide. Sorry, guys. Over the weekend, you guys are going to have 2 chapters of homework, chapters 2 and 3. They're long. Nothing I can do about it. They're long. Study in 10-minute increments. Go do something else while it digests. You'll do the read in your yellow book, chapter 2 and 3, and then take the tests on page 182 and 183 of your spiral book and grade them. We'll send you the homework and the wrap-up email. It'll be in there. Make sure you watch the video for dressing because I did not get to it. But as long as you remember, undress strong arm first, dress weak arm first, and put socks and pants on. Make sure everything is lined up right. They look good. That's really all you need to know. Keep them covered as you do it. That's what that privacy blanket is for. And once you watch the video, all that will make sense. I'm sorry I ran over today. I guess I got a little long-winded. Anybody have any questions before I let you go? Is class going okay for everybody?
Going good.
Am I going too fast? Am I overloading anybody? I know it's a lot of information, guys. I get it. It's a lot. I'm throwing a lot at you, but it should start to kind of click and make sense as we go. All right, you guys have your review sheets. Have a fantastic weekend. Do something fun. It's not all about school.
Thank you.
You're welcome. Have a great day. Thank you guys for joining us online. We will see you next week. Class on Monday, game show on Tuesday, and class again on Wednesday, and that will be our halfway point. So hope to see you then. Till next time, happy caregiving. Bye.